me everything. Yes, guys, can you hear me now? Yes. Yes, thank you so much. Yes, Narsimha Rao 6947. Thank you, thank you. So, where are you from, Andhra Pradesh? I stay at Vizag. I'm from Vishakhapatnam from Andhra Pradesh. Yes, MBBS 8981. Now, is it clear everything? Yes, okay. Yes, stage bingeal you can attempt because this is just there is nothing, nothing wrong in learning. No, no, Tej, it is good for you to listen to this lecture because I'm focusing only on PYQ because it will be very, very good if you attend this class. It will help you. Yes, you are from Kadapa, studying in Karnataka. Which college in Karnataka? Ayush Yadav. So you want to know which college I'm from, my MBBS college or my MS college or what? Mysore Medical. Okay, good, good. Chenagidra? So Sandeep sir and I have been in Karnataka, Davangiri for at least maybe 3 years. So ಸ್ವಲ್ಪ ಕನ್ನಡ ಬರುತ್ತೆ. Okay, now let's start the class today. So I have already told you the introduction, a brief introduction. Now we have started with the PYQ series. So each subject we are doing only PYQ, concentrating on the previous year questions because they are very, very useful. So now let us start. I have come up with the 5 years PYQ, that is 2021 to 2025 May. So let us start from 2025 May PYQs. So I'm not going to teach much. Please remember, no more core concepts. All we have to do is only understand the question and answer. If at all you have any doubts or if you want to revise something in detail a bit further, you have to know me. You should tell me in the comments so that I will teach only that particular topic. Right? Yes, hi. 6075. Okay, so the first question is on your screen now. A man falls on an outstretched hand. There is tenderness and swelling in the anatomical snuff box. X-ray was inconclusive. What is the most appropriate treatment? Yes, very good. Somebody who has answered this. Nuha Fatimat, very good. The answer is A. Ayush Yadav, are you a girl or a boy? Yes. So as soon as we see this particular question falling on outstretched hand, it is very, very common mechanism of injury for any trauma which is occurring in the upper limb. And now they have given us enough clues to tell that there is an tenderness and there is a swelling in the most important and the favorite question in the anatomy. So that is your anatomical snuff box. Anatomical snuff box. So you already know that the anatomical snuff box is related to what? So whenever you see this anatomical snuff box, it is related to one important carpal bone which is called as the scaphoid. So this is a very, very important carpal bone which is sitting inside your beautiful snuff box. And now because it is a trauma, they have taken the tenderness and the swelling. They have taken the x-ray of this particular scaphoid bone, but they couldn't draw any conclusion from it. That means the x-ray is not so, it has not proven that there is a fracture in the scaphoid. But what is the most appropriate treatment you do in this particular patient? Okay, Ayush Yadav, sister of Ayush Yadav, can I answer you that question at the end? So first let us discuss ortho and then we'll see whether it is suitable or whether it is not suitable for the girls. Okay, for that you have to listen the entire video. Okay, now, so we are dealing with the scaphoid fracture. So scaphoid bone is a very, very important bone and a very peculiar bone. So what is the peculiarity of the scaphoid bone? So it is prone to have AVN, avascular necrosis, right? And why is that avascular necrosis which is happening? This is because of the blood supply is from distal to proximal. So blood supply is from distal to proximal. This is all you know. It is an S-shaped bone. So this is somewhat like this. And when you see the blood supply, it is from distal to proximal like this. And whenever there is a fracture which is happening in between, that is the waist, so there is a chance of it undergoing into avascular necrosis. So the part of the bone undergoes into avascular necrosis, right? So now whenever you take the x-ray, so what are the x-ray views you have to do for this? So usually we go for the PA of the wrist or the hand, that is posterior anterior view or anterior posterior view, anything is okay. And next one we go for the oblique view. So this is a very important view which we take for the scaphoid bone. So now you remember anatomical snuff box is related to the scaphoid bone. You're going to check for the tenderness of the scaphoid, and if it is tender, you're going for the PA wrist and a oblique view. This is very, very important. So this oblique view can give a clear picture of your x-ray. And now even the x-ray is not very clear, then what you're going to do, you're always going to over treat in case of trauma. Please remember, under treatment is not agreed, over treatment. That means you have to be suspicious about the particular fracture. It could be an undisplaced fracture or it is not visible because of some, x-ray which we have not, maybe we have not focused on that particular area in the x-ray, or some view disturbances. So always what we are going to do, we are going to over treat. That means we are going to put the patient under a glass holding cast for 2 weeks, that is 14 days, and again you're going to review the patient. Again, you're not going to review the patient. So immediately you're not going to open reduction and internal fixation. That is never a choice, because you have to always have a confirmatory, any CT or MRI, and then only you're going for the surgery. And you cannot suspect MRI for the ligamentous injury, because usually there are multiple ligaments in the hand, and this particular injury or ligament cannot be noticed on the tenderness or on the x-ray. So usually scaphoid, what we think of is a fracture first, right? Fracture first. So you have this proverb like most common diagnoses are mostly correct. So you have to always think about the fracture in this case. And where urgent CT is that required, urgent CT scan. So what happens is, usually whenever the patient comes with the pain and the swelling and the tenderness, so clinically you are assured that there is some a disturbance which is happening in the scaphoid. So usually even in the CT scan, if there is an edema, you cannot pick it up properly. So we have to always go for the most appropriate treatment is the glass holding cast, and you have to follow up for the 14 days. So that is the answer for this particular question. So the answer is option A, right? So it is option A. So CT scan can be again done. And usually if you want to identify this particular fracture, usually we have to go for the MRI, right? So is that clear, guys? So we are going for which option? We are going for the option 1, that is a glass holding cast, which is usually given for the scaphoid fractures, and you're going to follow that particular individual after 14 days. So that is the answer. So this was asked in the exam recently in the 2025 May. Next question. A 55-year-old woman with the low back pain undergoes a bone scan. So please be assured that whether this particular examiner is talking about a bone scan or an X-ray or a CT or an MRI, because the terminology changes. So now we are dealing with a woman who is 55 years old, and now they are providing you with the bone scan. They have already identified that as a Honda sign. It's a Honda sign or a H sign, that too in the sacrum. So this is usually related to radiology as well, and because it is sacrum which is involved, you can also think it as an orthopedic question, right? So usually whenever you see such Honda sign, remember H sign or Honda sign is mainly for the sacral insufficiency fractures. So because the uptake of the bone is on the both, see, on the transverse and the longitudinal like this, so it is appearing as the H-shaped Honda sign, right? So you can see something like this. Okay, so this is your H-shaped Honda sign. So here I've given it clearly on the bone scan. So this is your H-shaped Honda sign. Okay. So the answer for the Honda sign or H-shaped H sign on the bone scan is your sacral insufficiency fracture. It could not be multiple myeloma, because usually the uptake is not much in multiple myeloma. It cannot be transient bone marrow edema, because bone, again on this bone scan you will not see this bone edema. And acute osteomyelitis, it is usually seen in other areas also, right? So usually this H sign or Honda sign is indicative of your sacral insufficiency fractures. Okay, so that is the answer for this particular question. Right, guys? Any doubt till now? Okay, moving on to the next question. 78-year-old patient presented with the IT fracture. What is the treatment of the choice? So now this is very important question, very important question. So usually they're asking this particular question, right? So you have to be very clear. Now let me just give you a detail of 3 important fractures. So the first one would be your IC fracture. The second one would be your IT fracture, and third one would be your fracture shaft femur. Okay, now please pay complete attention here. Now this is what, hi med nerds, hello. So now till now, see, this Honda Sun or H sign is sacral insufficiency fracture. It is somewhat a memory based question, right? Okay, so this you have to remember. There is no concept or no thing about it. Maybe based upon the option, sometimes you can rule it out, right? The first question, again, a bit of concept oriented. So we have discussed that concept. So usually whenever it is an anatomical snuff box, scaphoid fracture, they're usually missed fractures. So for that, you have to either go for an oblique view and confirm, or even if the oblique view is not so confirmatory, you go with the treatment of the casing, and after 14 days, you will again review the patient. That is a clear concept you have to have in your mind. And now this particular question is also very much concept based. So you have to understand three important concepts here, so that any question which is asked about IC fracture, IT fracture, or a long bone fracture, you're going to just write it, or you're just going to do it very neatly and easily. So first remember, whenever I talk about an IC fracture, it is an intracapsular fracture. So intracapsular fracture or fracture neck of femur. So neck of femur, right? So I'm talking about neck of femur. So here what happens is, there are certain criteria for it, for the treatment. So the first criteria you have to remember is the age. Age is a very important role whenever you're going to treat your IC, that is intracapsular fracture. So if the patient, just remember two things. If the patient is a younger patient, whenever I say young, that means not a teenager, it is less than a 50-year-old patient. Whenever I say old, that means a older patient who is more than 60 years old, right? So then you have to ask me, what is the age, what is that between 50 and 60? So 50 and 60, you have to again consider the patient comorbidities and again patient other conditions, and then go with the treatment. So usually what they will give you is, they will give you either a young patient, that is maybe they will tell you it is a 40, or they will give an older patient, maybe 60, 70 and 80. So usually they will give you a clear-cut age. Don't worry about the age now. Just see the question, whether they have mentioned a younger patient or they have mentioned an old patient, right? So here, why I'm telling you young or old? So in the young, we don't want to operate much. So we have put one important and interesting word for them. Remember, it is osteosynthesis. Now, nothing to mug up. Just follow the words. Osteo, bone. Synthesis, anything synthesis, photosynthesis in intermediate you have learned. That means you're taking the light and preparing something. This is osteosynthesis. So they are preparing bone, right? So young people are ready to prepare the bone. So they are doing osteosynthesis. But for the old, then what are you suggesting for the old? I am suggesting a surgery which is called as hemiarthroplasty. Again, nothing to by heart. Just come with me, break down the words. What do you mean by word hemi? Hemi is nothing but half. What do you mean by arthroplasty? Arthroplasty is nothing but a replacement. Arthroplasty is a very dynamic emerging branch, a subspecialty of orthopedics for many young orthopedic surgeons nowadays. So they have been like mastering the replacement surgeries nowadays. So arthroplasty is very emerging. But now I have told you it is only a hemiarthroplasty. That means only half replacement. So usually if you come down again and ask me what is this half replacement, so going back to the basics, a joint is how it is formed. It is always formed by two articulating surfaces. For example, if I want to tell you about the hip joint articulation is between the femoral head and the acetabulum, if you remember. So now I am telling you, this is only half replacement, and you already know that in IC fracture there is a fracture of the neck. So the femoral head has to be replaced, right? So the femoral head has to be replaced. So what do you mean by hemiarthroplasty? So hemiarthroplasty is nothing but, coming back to the basics, replacement of the femoral head. So this is called as the hemiarthroplasty. Now, how do you replace any anatomical part of the body? So you will always replace an anatomical part of the body by an implant which is called as prosthesis, which is called as prosthesis. And now again you have to ask me, what is this prosthesis? Are there types of prosthesis? Yes, there are types of prosthesis. The first and foremost what they have used was the Moore's prosthesis. Then they have come up with the collar, which is called the Thompson's prosthesis. But now we are in the era of using a very important prosthesis, which is called as the bipolar prosthesis. Again, the terminology bipolar. Why it is called as bipolar? That means these two are unipolar. Yes, these two are unipolar. This is bipolar. Bipolar doesn't means nothing, but there is a movement. There is a dual movement which is happening in the one in the prosthesis and one between the head and the acetabulum. So this is all about the your IC fracture. Now you have to ask me, what is osteosynthesis then? You have told hell a lot of story about hemiarthroplasty, nothing about osteosynthesis. Yes, I'm coming back there. Osteosynthesis, I have told you that bone is formed. So half the bone is formed. Now what we are using is, we are using CC screws. CC screws, what do you mean by CC screws? Cannulated cancellous screws. Now you go back to the internet and type CC or cannulated cancellous screws. You will get this screws, right? And now these have threads at the end like this, right? And these are cannulated cancellous screws. Why? What is the word cannulated? So there is a lumen inside the screw, so that I can pass a guide wire like this through the screw. So I will put the guide wire, which is very thin wire, and over that guide wire I will pass the screw and I will fix the bone. So how do I fix the bone? How do I fix the femur? So if you think this is the femur, neck of the femur, so I put 3 screws like this, right? So it is a reverse triangular fashion. So reverse triangular fashion like this. So 3 screws, inverted triangular fashion. So inverted triangular fashion, 3 screws. So this is called as the osteosynthesis. So this is 1 screw, this is 1 screw, and this is 1 screw. And now this is not a very demanding procedure, because you're not going to cut entire thing. You will just take an incision which is sufficient to put that particular screws. That's it. Okay. Hemiarthroplasty is a major surgery. You have to cut entire buttock. That means all your gluteus muscles. You have to isolate the sciatic nerve, then take care of all these muscles, and then you're going to enter the joint. Then you're going to remove the head. Then you're going to drill the marrow, prepare the marrow of the shaft, and then you're going to put the prosthesis. So for the young individuals, you don't want to do all this big procedure. So we are going for the osteosynthesis. Is this clear? Yes. Yes, is this clear? Very good. So now you have to ask me, ma'am, you have told me that there is a hemiarthroplasty. Then, ma'am, is there any total arthroplasty? So that is what your brain should work, not about mnemonics. So somebody is telling hemi, then you should ask them why the word hemi has come. Do you think there is one more word which is called as a total or a complete arthroplasty? Yes, there is a total or a complete arthroplasty which is called as the total hip replacement, that is the THR. Now, my dear students, you can all tell me what is THR, total hip replacement. When I say hemi is only replacement of half of the joint, then what do you think the THR would be? So THR would be the replacement of the entire joint. Entire joint ka matlab both your acetabulum and your femoral head, right? Right? No more confusion, right, between THR, hemiarthroplasty, osteosynthesis. Yes, acetabulum also. That is why it is called as total hip replacement. So how do you replace your acetabulum? You have this acetabular cups. So you have the cup like this, and then you're going to put your femoral prosthesis like this. So you're going to replace both the acetabulum and the Acetabulum as in not complete acetabulum, the cup, we are going to put the cup, right? So then you are going to put the femoral head into it. So we are going to replace the acetabulum and the femoral head, which is called as the total hip replacement. And now you have to ask me, when are we going to do this total hip replacement? When we are going to do the hemiarthroplasty, right? So for that, the answer would be, if the patient is a young individual, very active, and in the age of 70 years also, if is very active, then you can go for THR directly, because by 70 years there will be acetabular degeneration as well. So there will be arthritis of the acetabulum as well. So you don't want to put this patient to again subject him to total hip replacement after over a period. So now you can directly go for total hip replacement, right? So these are all the surgeries which are available for IC fracture. Based upon the questions, you're going to select the option, right? So now I have told you so much about IC fracture, right? So then let us deal with the IT fracture, and we'll take a new page for femur shaft fractures, right? So is this clear? IC fracture, we have so many options. So first is osteosynthesis. CC screws, you have to remember the implant which is used in osteosynthesis, that is CC screws, right? Then we are going to deal with hemiarthroplasty. So we have prosthesis for it. We have Moore's prosthesis, Thompson's prosthesis, bipolar prosthesis. So how do you identify the Moore's prosthesis? Your mnemonics, there are two O's, and in that particular prosthesis also there will be two holes like this. That is Moore's prosthesis. Then how do you identify the Thompson's? Thompson's is again, after you're having this particular head, you will have a collar like this, right? So there is a collar around the head. So that is your Thompson's prosthesis. And having no holes, no collar, and simply, the head with a slight stem like this. So this is your bipolar prosthesis. So bipolar, again, it is having dual movement in the prosthesis. You can't identify it. So just remember, whenever you want to identify a prosthesis, if there are two holes in the stem, that is Moore's. If there is a neck, it is a Thompson's, and nothing is there very sleek, it is bipolar prosthesis. Total hip, you have to identify the acetabulum as well. So acetabulum also is replaced by the cup. So that is your total hip replacement. Okay, that is everything about your IC fractures. No more no more doubts. Okay, no more asking anybody, no more confusion in the exam. Go kill it. Okay, yes, thank you, MBBS 8981. Yes, avian also. Avian is avascular necrosis of the femoral head. Very good question, Mednuts. So avian is avascular necrosis of the femoral head. There also you can go with hemiarthroplasty, but remember, Gururaj Basaya, please wish me. Okay, all the best. All the best. Okay, so now you have asked a very good question. Let me answer that. So for avascular necrosis also is the treatment AVE. So what happens is, avascular necrosis is a condition where there is a complete damage to the femoral head and there are stages in it. If it has reached the grade 4 stage, that means there is some amount of acetabular degeneration as well. So in that stage, you will usually go for total hip replacement, right? Yeah, we are going further, don't worry. Next, we are dealing with the IT fracture. So IT fracture, so now I have told you so much about the intracapsular fracture. Now it is the extracapsular fracture. Extracapsular fracture, what is the meaning of it? That means it is outside the capsule. That means it is an IT, that is intertrochanteric fracture, which is in between the trochanters, That means how many trochanters do our femur have? So one is your greater trochanter, the second one is your lesser trochanter. So any fractures between these two, so greater trochanter and the lesser trochanter, is called your IT fractures, right? So why not we are dealing with the hemiarthroplasty in IT fractures also? Why are we going with another type of treatment? So this is not covered with the capsule. Here the neck is not damaged. That means vascularity is maintained. So everything is scientific, and you have to always concentrate on the basics. Basics is the must. See, everything is anatomy again. You see, in IC fracture, whenever I tell the word IC fracture, this is also a femur like this, right? But what happens here, there is a fracture neck here. The fracture happens here. And if you know, the vascularity is like this, right? So if you go back to your anatomy and see, the vessels are going from the distal to the proximal through the neck. So whenever there is a fracture in the neck, there is a high potential chance for the femoral head to undergo avascular necrosis. So even though if you fix it for the elderly patients, it may not take up, and it again may land up in the failure of the surgery. So that is why for the elderly patients, we go for hemiarthroplasty. But when I come to IT fracture, the neck is not damaged, the vascularity is maintained. Only problem is there is a fracture in the intertrochanteric area, where you have to fix it, because femur is a weight bearing area, right? So you have to fix it. So for that fixations, we are taking the help of proximal femoral nail. So that is the beauty. So whenever you see the fractures of IC and IT, you have to first see whether it is an IC fracture where it is damaging the vessels, creating the avian of the head, or it is an IT fracture where the vessels are in contact and we can get away with the proximal femoral nailing. Right? So this is proximal femoral nailing, or it is short form, which is called as PFN. For that, the fracture has to be extracapsular. Right? So that is IT fracture, and usually this is the most common fracture in the elderly. If you go back again to your basics, you can remember this is the most common fracture which is seen in patient over 60 years. That is your IT fractures, right? And if you go back to your what is difference between IC and IT, you will see the extracapsular, the external rotation is more. So external rotation is more, the shortening is more, right? So all these details you see in the theoretical part, right? So, and coming to surgical part, the treatment is proximal femoral nailing. So what we do? We put the patient and cut the muscles here. So this thigh muscles we cut here and we enter like this, and we will palpate the greater trochanter. So for this we are going to put the nail inside it. So you will put the nail like this inside it. So it is an intramedullary nail. And now you should ask me, what is the difference between the proximal femoral nail and the intramedullary nail? So are they similar? No, they are not similar, because once you put the nail, you are going to put two screws, so two proximal screws into the head of this particular fracture. So this is, and again there will be one more screw here. So this is called the PFN, proximal femoral nails. Okay, my nail is appearing to be little reverse. Okay, let me put the threads this side. Okay, like this. Okay, the threading like this, and the nail heads here, right? Okay, now concentrate. So what is PFN? PFN is something where you see the nail in the medulla and the two screws in the head. So you can call this as a cephalomedullary nail, right? What do you mean by cephalomedullary nail? What do you mean by cephalo? That means head. Medulla is the medullary canal. So this is an example of a cephalomedullary nail. That is your PFN, which is used for your IT fracture. There is one more important implant which is used for IT again, which is called as a DHS. It is nothing but, if you think this is your again, let me draw your femur. So now this DHS is again different, because this is also having a screw, no doubt, because all the IT fractures will have the screw in the head. But here what happens is there is a plate instead of nail. If you see a plate on the femur, and if you see some screws like this into the shaft, so this is your dynamic hip screw. This is your dynamic hip screw, but you will have a screw plus a plate, not a nail. So these two are the treatment of your IT fractures. Not to forget, we have two important treatments. One is your PFN, which is the first and foremost, and this is your DHS. So second one is your DHS. So you have to look for the options. First option, if you have PFN, it is proximal femoral nail. Next is the DHS. Right, guys? So now, having said so much about the IT fracture, can you now answer this question? A 78-year-old patient presented with the IT fracture. What is the treatment of choice? Is it a hemiarthroplasty? Is it a femoral intramedullary nail? Is it as a proximal femoral nailing or a derotation boot? So what is the answer? Excellent. This answer is C, that is your proximal femoral nail. Right, this derotation boot was also a treatment. It was given as a conservative treatment for your IT fracture. It is not at all used now. Okay, this is an obsolete procedure. History. Okay, is that clear? So now I'll take a 1 minute here, 1 minute more, just to confirm. See, now this is again a femur, right? Don't worry about the femur, worry about my implant, that's it. Okay, okay. Now you see, so what is the difference between this? So again, for intramedullary nailing also, what I do is I go from the GT again, I will put the nail. So imagine that this is my nail into the femur, and now I'm trying to tell you the difference between the intramedullary nail and your proximal femoral nail. So whenever you want to name it as an proximal femoral nail, be sure that the screws are in the head, the cephalomedullary nails. And now coming to this intramedullary interlocking nail. So there is nothing to do with the head. There are two screws which are present here on the proximal side, right? And two screws on the distal side. So there is an intramedullary nail and there are two screws which are locking the nail. So this is your intramedullary interlocking nail, right? Difference is clear. So this is used for your femoral shaft fracture. So this is for your femoral shaft fractures or a tibia shaft fractures, that is your intramedullary interlocking nails for any long bone fractures. Any long bone fractures. Is that clear? So this is about all about the nails. Very important for INICET because from the past 2 years they have been asking at least one question from IC or IT. Okay, good. Next. A female patient with rheumatoid arthritis presents with cervical pain. What is the most likely cause? I think very important. Rheumatoid arthritis is a very important topic for any competitive exam, and what you have to remember is rheumatoid arthritis is a disease which is called as an inflammatory arthritis. It is an inflammatory arthritis, so it involves multiple joints, so which is characterized by the polyarthralgia. So polyarthralgia, and you have to have certain diagnostic criteria. So this usually involves the small joints, especially the joints of the hand, and in the hand especially the MCP has to be involved. So the metacarpophalangeal joint has to be involved, plus your proximal IP joints, right? So this is what is the involvement in case of your rheumatoid arthritis, which is characterized by the morning stiffness at least for 1 hour, right? And then it involves mainly the joints which are usually the knee joints is usually involved for arthritis, right? And when it comes to the cervical spine, the spine which is only involved is the cervical spine. So we have come up to that level where we know the only spine which is involved is the cervical spine. But INICET is a core exam which will examine the depth of your knowledge. So in that cervical spine, what would be the most common cause of a patient complaining about the cervical spine? So here the answer would be atlantoaxial subluxation. So this is the most important cause in case of your rheumatoid arthritis, because there is a degeneration of that particular atlas which will result in the atlantoaxial subluxation, right? So that is the answer. So the female patient, so they have already given female patient usually with rheumatoid arthritis with the cervical spine. involvement, the most important pathology underlying it would be the atlantoaxial subluxation. Right? So osteoporosis can be seen because usually young patients present with the rheumatoid, right? Osteoporosis is usually seen in the elderly female, but in these people also you can see osteoporosis because of the drugs, because of the steroids they use, but that is not the main cause. Again, porosis and arthritis is again same, degeneration, right? And stenosis also again degeneration. But here the most common cause, again commonly correct, common diagnosis you'll be commonly correct. So this pathology is mainly due to atlantoaxial subluxation. Okay. Yes, very good. And remember all this chota information about the rheumatoid arthritis. It is an inflammatory arthritis, polyarthralgia, morning stiffness, common in females. Yes, and now you are trying to diagnose it based upon anti-CCP antibodies. So what is the diagnostic? More specific is anti-CCP antibodies, and you already know that they should be an RA factor which is present. They should be raised ESR-CRP because they are again the inflammatory products, right? So this is all the information regarding the rheumatoid arthritis, but the special thing you have to remember is the involvement of cervical spine and the atlantoaxial subluxation. Clear? That is about the rheumatoid arthritis. Yes. So now, yes, now I want you all to answer this without any help or without any discussion. I'm going to the next question. So what is the answer of this? A 70-year-old female with extracapsular neck of femur fracture. What is the best step in management? Perfect. Very good. This is what I want. So because they have not given PFN, again you should not be confused, right? It is the dynamic hip screw. Very good, very good, very good. I'm very happy. Yes, very good. So no discussion on this. I'm going further. Very good. I'm very happy. I'm very happy. So many of you answered right. Yes. Now coming to the again important question. Definitely asked in INICET, nerve injuries you shouldn't leave. You're going for an exam, NEET PG, either NEET PG or INICET. From ortho, if you want to answer one question at least, do nerve injuries. So now what is the answer for this? Deep branch of the ulnar nerve supplies all the following muscles except. Now if you see the options, everything is supplied by the ulnar nerve. So that is the beauty of the INICET. You have to be little depth of the knowledge is important, right? So opponents digiti minimi, the third lumbrical, the palmar or the dorsal interossei or the flexor carpi ulnaris. Yes, don't jump into the answer. This answer is little tricky. Okay. So now let us see what is that. So now when I talk about the ulnar nerve, you already know that there are multiple muscles which are supplied by it. So what you have to remember, this is the hand of a musician's nerve. So musician's nerve, because the fine movements, all the fine movements are done by the hand, and most of the muscles in the hand are supplied by the ulnar nerve. So again, I'm going to tell you in detail. Don't think that madam is eating our brain, but this is very, very important. So the first thing what I want to tell you is the intrinsic muscles of the hand. So what do you mean by the word intrinsic? I think many of you know. See, all these intrinsic muscles in the hand, they take origin in the hand and they get inserted in the hand. Hence, they are called the intrinsic muscles, right? So what are those muscles? So they are the lumbricals, and you have your thenar, similarly hypothenar, and then you have your dorsal interossei and the palmar interossei. Good evening, Nishu. Now MBBS 8981, no more scaring of any questions. Now you see how beautifully you will answer from now on. But please put little concentration here. So now always remember, whenever they're talking about the hand, there is nothing to by heart. There are 5 group of muscles: palmar interossei, dorsal interossei, thenar, hypothenar, lumbricals. So interossei, you know, thenar, you know, only lumbricals you have to remember. So these are the 5 group of intrinsic muscles of the hand, right? And now when I say musicians, that is the ulnar nerve, so the majority of them should be supplied by the ulnar nerve. So the interossei are supplied, hypothenar are supplied by the ulnar nerve, and in the lumbricals, the again third and the fourth lumbricals are supplied by your ulnar nerve, except thenar. Thenar is why your median nerve. Again, there is a confusion here. Again, this median nerve, this thenar muscle, there is one important adductor pollicis, our favorite adductor pollicis, which is again supplied by your ulnar nerve. Right? So now all the red marks, ulnar nerve. So all the hypothenar muscles, your palmar interossei, dorsal interossei, adductor pollicis, and the third and the fourth lumbricals. You see, all this majority are supplied by your ulnar nerve. That is why this is very, very important nerve for the functioning of the hand, for your fine movements of the hand, right? And now again question appears. If there are intrinsic muscles, ma'am, what are extrinsic muscles? So extrinsic muscles of the hand are muscles which are originating in the forearm and taking insertion into the hand. So one such important is your FCU, your FDP, which is again supplied by your ulnar nerve. So here what happens is, because ulnar nerve is supplying majority of your hand muscles, it is little tired. So in the superficial muscles, so in the forearm muscles, it is supplying only two important, flexor carpi ulnaris, FCU, and medial half of the flexor digitorum profundus. So this is it. This is it. You have to remember about the ulnar nerve. Flexor carpi ulnaris, medial half of flexor digitorum profundus, and your all these intrinsic muscles. All these intrinsic muscles. And now some majority of you might think, ma'am has given only two flexors. What about those flexor superficialis, flexor digitorum superficialis, flexor carpi radialis? What are all those, the other flexors? What happened to them? So flexor carpi radialis, pronators, and all those all are supplied by your median nerve. Understood? Nothing to by heart. Whenever the term flexor other than carpalis, other than profundus, mark it as median nerve. And if there is a word about ulnaris and profundus, be very careful. When they talk about the medial profundus, it is ulnar. Lateral half of profundus is your median nerve. And now so much about the flexors. What about the extensors? So all the extensors are supplied by our favorite radial nerve, right? That's it. This completes your nerve injuries. Synonymically same. That means what does that means, Nishu? So all the extensors, whenever somebody is talking about the extensors, there are all the extensors are supplied by the radial nerve. Period. Okay. Then coming to the flexors, there are certain flexors. Flexor carpi ulnaris, the name ulnar is present. Flexor digitorum profundus. Whenever FDP, FECU sounds similar. Yeah, because see, all the flexors, there are 5 flexors if you remember. Yeah, all are flexors, right? So flexor carpi radialis, flexor carpi ulnaris, because there are 2 bones, there are 2 forearm bones, right, in the forearm. So there is radius and there is ulna. So flexor carpi is same, but the third one is different. So third one is radialis, R, and this is U. And here what you have to remember is only P, that is flexor digitorum profundus. The all other flexors are supplied by the median nerve. Only these 2 flexors are supplied by the ulnar nerve, and all the extensors by the radial nerve. Okay? Yeah, you keep on practicing, then it will become easy. Nothing, if you hear for the first time, very good. Here for the first time it will be same. Okay. Now what is the question? The question is the deep branch of the ulnar nerve. So this ulnar nerve till here it supplies all the flexors, that is flexa carpi ulnaris, and up to the wrist. That means till here means up to the wrist it supplies your long flexors. So flexa carpi ulnaris and digitorum profundus are called the long flexors. So it is supplied by the direct ulnar nerve. At the wrist it divides and give a deep branch which supply all the muscles of the hand. And now can you name the muscles of the hand here? Yes, now can you name the muscles of the hand? Palmar dorsal, muscles of the hand. Third lumbricals, muscles of the hand. Opponent's digiti minima is an hypothena muscle. It is a muscles of the hand. So the answer here is, what is the answer? Yes. Yes, I want everybody to answer now. What is the answer here? Very good. So the answer is flexa carpi ulnaris. Got it? Feeling little easy? Yes, very good. Everybody type the answer. Yes, okay. So just keep on revising. Now as you go home, ask your friend what are the muscles which are supplied. Then next day you ask what are the thenar muscles. So next day you ask what are the hypothenar muscles. So that you should keep on revising. If you keep on revising, it will be easy, it will be familiar, it will be very, 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 very interesting as well. Okay? Hope now the confusion has ended here. Yes, okay. Okay, after such interesting question, this is a very, very easy question. So sunburst appearance is seen in a direct question. I wish this has to come in the exam again. Yes, sunburst appearance. Very good. This is like, if somebody is doing wrong, it is like a nightmare for me. Nobody is going to do this wrong, right? Sunburst appearance, osteosarcoma. But just revise, what is osteochondroma? Osteochondroma is nothing but your growth, right? It is also called as exostosis. Okay. And then Ewing sarcoma, how does it look like? Ewing sarcoma on the x-ray, it looks like your onion peel appearance. Just revision, okay? Onion peel appearance, exostosis, osteosarcoma, sunburst appearance, and your Codman's triangle. And there's fibrous dysplasia, your Shepherd-Crook deformity. Shepherd-Crook deformity, right? Shepherd-Crook deformity. So these are direct questions. They have been asked. Arjun Singh, what you don't want to pursue? So these are certain deformities on the X-ray. So I'm just expecting you to answer. That's it. So sunburst appearance is in osteochondroma, Ewing sarcoma is onion peel appearance. Right. And then fibrous dysplasia is the Shepherd-Crook deformity. On the X-ray we see, right? So that is the answer. Shepherd-Crook deformity was again asked. That is a PYQ, very, very important PYQ. Okay. Done. Then next, what is the investigation of choice for tuberculosis of the spine? Was it an X-ray, CB-NAT, culture sensitivity and CT scan? What is the investigation of choice? This is a very interesting question. See, INICET, very easy. But you have to know. You have to know the subject. Then only it is easy. Jayant. Are you from the final year, Jayant, or the second year? So people from the second year, I mean, who have recently learned microbiology would go for culture and sensitivity, forgetting that how long it takes for the culture and sensitivity. Is it the LJ medium, tuberculosis? If I'm not wrong, is that the answer? B, I guess. MBBS. Passed out. Okay. Passed out ka matlab you have passed out the MBBS or you passed out second year? CT scan. Purushottam, we are talking about tuberculosis. Very, very interesting bacteria. Oh, MBBS, you have passed it. Okay, good. So you will answer. You will understand why I'm not. Why? See, if somebody is asking this question, tuberculosis of spine, that means there should be some speciality of it. Simply they won't ask why. What is the investigation of choice? Then why didn't they ask about salmonella? Why didn't they ask about Staphylococcus aureus? Okay. So the interesting thing about bacteria tuberculosis is Mycobacterium tuberculosis. India is struggling to control this bacteria. Okay. So first talk about X-ray. Nothing you can see on the X-ray and confusion. Every infection looks like your TB. Very much big confusion. Next, culture and sensitivity. If I am not wrong, you people only should correct. Otherwise, Anusha ma'am will kill me. That is the long LJ medium for maybe for tuberculosis. I don't remember exactly. So this is for culture and sensitivity, but it will take 6 weeks for the result. It will take 6 weeks for the result. Will you wait 6 weeks for result? No, right? And CT Lounston-Jensen's, correct? Then CT scan also, it is not at all. We can't tell that this is not a tuberculosis or this is not this particular thing. What we can actually do is we can go for biopsy. So biopsy is the ultimate guide for us. But good evening, Javed. But nowadays we have evolved with biochemistry, with nucleic acid amplification, right? So what is this nucleic acid amplification? So even though we have minute amount, it gets amplified and will tell you the result in just an hour. So that is the CB-NAT. That is the beauty of the CB-NAT, and this is considered to be the most important investigation. That is your CB-NAT, cartridge-based nucleic acid amplification test, which is very much useful for identifying and diagnosing your tuberculosis, because tuberculosis is a very, very rampant infection, has to be treated very for a longer duration, and a very important infection, right? So the answer is CB-NAT. See, if you know the answer CB-NAT, it is very easy. Nothing to use, no brain to be used, X-ray not used, culture and sensitivity is not used, CT scan is not used. And ask me, how can we improve this knowledge, ma'am? So this is very, very clinical question as well as theoretical question also. You have to know the basic, and then so these type of questions can be answered only and only if you attend your postings. So internship will teach you this kind of question. So in the internship, what we'll do, what we actually do is, whenever your PG or your surgeon is removing some tissue from the tuberculosis, and then he will tell you, doctor, send this for this for this. Then you will learn. So this particular is sent for CB-NAT. So this tissue has to be sent for biopsy. This tissue has to be sent for CB-NAT. This is sent for culture and sensitivity. So your postings, your internship postings are very, very important to answer such questions. Without attending postings, how much ever you sit and read the theory books, you will try to get confused. Okay? So that is the importance of attending the postings. Okay? And now, answering these questions will tell you the importance of sitting and reading. Sequestrum is a piece of dead bone that has become separated during the process of necrosis from the normal or a sound bone. So he has given you the entire definition of what is sequestrum. Beautifully, right? A piece of dead bone which has separated during the process of necrosis from the normal or a sound bone. So what is the ring sequestrum is seen in which following conditions? So here he want to ask you about the ring sequestrum, but he's a very good person. So he has given you the definition also, sequestrum also, because he wants to tell you, I'm asking about that particular sequestrum, which is, seen in infection, and ring sequestrum is seen in where? Yes, very good. So ring sequestrum is seen in the pinhole infection. So external fixation. So whenever you're doing external fixation, this is the limb and we are fixing it with the rods and you're making a small hole here and putting the pins in it, right? So you put the pins in it. So whenever we are doing pins in it, we are making a hole here on the skin and we are putting the pin, right? So whenever making the hole, there is a small gap which is left between the skin and the pin, and this can be medium for the bacteria to grow, and this will form as a ring sequestrum. Okay, ring sequestrum. Very good. So this is a straightforward question. So this is again a theory for all those people who sit and read. So this is the answer. Ring sequestrum is seen at the infection at pinhole of the external fixator. Okay. So now you go back home and read what are the types of sequestra. Okay. There are fine sequestra, coarse sequestra, coke type sequestra. Okay. Ivory sequestra, like that. So there are types. You have to draw a beautiful tabular form and then read all the sequestra. But for now, ring sequestrum is seen in the infection of the pinhole. So most of them have answered it correct. So I am not giving you the table. Next, this is a very big question, interesting questions. Whenever you see the big questions, don't get panicked. That means they have given you more information. That means it is even more easy for you to identify. So now they are talking about a 40-year-old female here, right? So once they talk about the female, that means some inflammatory things are happening in her body, complaining about the bilateral wrist pain. So 2 wrist pains. She also reports fatigue and low-grade fever. Okay, on further questioning, she states that she has morning stiffness for more than an hour, which is very, very important. And swelling of the bilateral wrist is seen on clinical examination. And again, there is an IgM antibody which has been isolated from the body against this IgG. And X-ray was taken, which is showing destructive arthritis. So before me reading the long question, most of you have answered beautifully right. That is rheumatoid arthritis. So we have dealt with rheumatoid arthritis. I have told you that the polyarthralgia, more than 1 hour, RA factor. Here they have not given RA factor directly. They have told you that there is an IgM antibody which is against the Fc component of IgG. That means this IgG is present in the body. For this Fc component, there is an antibody which is IgM, and this is nothing but your RA factor, right? And again, whenever you see the X-ray, the features of X-ray in rheumatoid arthritis is very, very simple. Usually it is bilateral, symmetrical, right? And you see juxta-articular osteopenia. That means around the joints, you see there is a decrease in the bone density, which is called as juxta-articular osteopenia, right? So juxta-articular osteopenia, and you see most of this destructive arthritis, and they land up with the deformities because of this destructive arthritis, right? So there is one important thing which you have to remember is juxta-articular osteopenia, and then you have to remember that there is destructive arthritis, and because of this destructive arthritis, they land up in your deformity. So what are the 2 important deformities in the rheumatoid arthritis? So one is your swan neck deformity, the second one is your Bottinier's deformity, right? The swan neck deformity and the Bottinier's deformity. This you have to remember. Swan neck deformity and your Bottinier's deformity, right? Yes. And there are multiple deformities which you can see in the hand. Yes, hallux valgus. Yes, what is hallux valgus? Hallux, Hullux and valgus. So it is the toe deformity, right? The great toe deformity, right? You can see the Z deformity. And all such deformities you can see in case of your rheumatoid arthritis. Okay. Yes. Yeah, it is hallux valgus. Very good. So now tell me, what is Wernicke deformity and Bottinus deformity? Again, they will ask you what is Wernicke and what is your what are you asking? Ankle Reiter syndrome. Yeah, Reiter syndrome is one STD. It is one type of STD where you can't see, can't pee, can't knee. Don't remember? So this is a condition where you have can't see is your conjunctivitis. Then can't pee is urethritis, urethra. Can't knee is your arthritis. Okay? Yeah. Finally, I've given you some mnemonic today. Yes? So can't see, can't pee, and can't bend the knee. That is the Reiter syndrome. Yeah, it's a triad. Yeah. Good. Okay, now what is swan neck deformity and Bottinus deformity? Swan neck is where you have the flexion deformity in the DIP, and where you have flexion in the PIP is your Bottinus deformity. Right, you have to remember this because it is again an image based question they will ask you regarding the rheumatoid arthritis. Right, lupus arthritis is your SLE. SLE, again seen in females, most commonly seen in females. And you know what is ankylosing spondylitis? Very, very important. HLA-B27 associated. You have to read about this. Very, 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 very important. Right? The multiple things about this. Usually seen in the young males, and you see very important dagger sign. Right? So this dagger sign was asked in the NEET PG. So that is your ankylosing spondylitis. So this ankylosing spondylitis, all inflammatory conditions. Ankylosing spondylitis is HLA-B27. You see the involvement of the axial skeleton. Axial skeleton ka matlab, what is the, yeah, bamboo spine. Yes, axial skeleton is where the involvement of the spine and your SI joint. So SI joints and the spine are involved. Axial skeleton, ankylosing spondylitis, dagger sign is very, very common. Then rheumatoid arthritis, we know entirely about rheumatoid arthritis. What they will ask you is about the RA factor, and sometimes they'll put the X-ray, they will give you destructive arthritis. So there is a lot of destruction and resulting in deformity. Most important deformity is Van Eyck and the Bottinus. And coming to Reiter syndrome is a triad of things which can happen: conjunctivitis, urethritis, arthritis. That is your Reiter syndrome. And lupus is SLE related lupus arthritis. Yes, bamboo spine is also seen in your ankylosing spondylitis. Yes, the next question. Osteoporosis is defined as a decrease. This again, he is defining what is osteoporosis. This is actually a question, not an answer. So osteoporosis is defined as a decrease in the bone mineral density with resultant trabecular and corticular bone loss. Patients with osteoporosis have normal serum calcium phosphate, alkaline phosphatase, and parathyroid. Everything is normal, it seems. So which of the following test is commonly used? So he has given entire answer only and is again testing our knowledge. So let us see. What is osteoporosis, by the way? Yes. Yes, you should also keep answering so that it will be interesting for me also. I'm not asking the answer. What is osteoporosis? I'm asking. So if I want to tell you about osteoporosis, I will tell you that this is a degenerative condition where there is a loss of bone mineral density, right? So there is a, oh yes, age related demineralization. Okay, now if you take this as your bone and this is the mineral. So whenever I talk about this thing, your osteoporosis, there is a decrease in the bone as well. So there is a decrease, but the mineral is, the bone to mineral ratio is maintained. That is what they want to tell you. Yes, the quantitative defect. Very good. So this is your osteoporosis. And now you all know what is the this thing, the DEXA scan. investigation for osteoporosis is your DEXA scan. What is DEXA? Dual dual energy X-ray absorptiometry, right? That is your DEXA scan. So DEXA scan, what you do is you scan the calcaneum or the vertebrae, and now you will have certain values which you compare to your normal individual, or that means your peer group or a normal individual. So they will have two scores, the Z square and Z score on the, what is the other score? T, right? The scores, they give scores. This is mainly the standard deviation. Now go back to your SPM and you know that there is a standard deviation, right? So they will set up a standard and they will see how much you are deviated from the standards. So for example, if you are answering this particular question, like your INICET and your NEET PGs, they will tell who is the topper. So that fellow is the standard, and from then they will tell you how much we are deviated from that particular topper fellow, right? So if that particular fellow is getting some 60 out of 100, so that is the standard. So everybody should get 60, and then they will tell you how much you are far away from that 60. For example, you are 58, 59, 57, 50, 40. So how much you are deviated from the 60 is your standard scores, right? So similarly, osteoporosis also is using the same formula. They are setting up at the age of 60 years, this is the standard. That is, standard is 2.5. And if you're deviated from the standard, so if you're not into a 2.5, you're 1.5, you're less than 2.5, 1.51, then you're osteoporotic. Okay. So similarly, that the DEXA scan is used, right? So you have understood, right, what I'm trying to tell you, the Z scores and the T scores. So these are two important scores. So one score is related to the normal individual. So thinking that, assuming that this fellow, a normal 25 years individual, how much the score is having and how much you are deviated, that is your Z score. And then T score is your peer individual. So how much you're deviated from your normal, like you're 60 years, she's 60 years, but that 60 years she's having good bone mineral density. At the same 60 years, how much you are deviated from that normal bone mineral density. So that is how you have to understand. But just remember the thing, whatever it is, Z dot T score, we have only one number, that is 2.5. If that is less than 2.5, then you are osteoporotic. And again in this 2.5 to 1.5, less than 1, so you are moderately severe osteoporotic. If it is less than 1, you are severely osteoporotic. So all this drama is for your DEXA scan, dual energy X-ray absorptiometry. That means it is nothing but a form of X-ray only, right? So you're using DEXA scan, that is for sure you know that the answer is DEXA is there. And then he has only given you all the chemicals, right? Calcium phosphate, alkaline phosphate, parathyroid, all had been used. So chemical analysis is definitely used. And one more thing, we use the bone scan. So if you remember the stress fractures, the osteoporotic fractures, what we use, the mode of investigation is through the bone scan. So we use the bone scan. And finally, if any patient comes with the pain in the older female, we usually first write the X-ray. So we are using the X-ray. The only thing we don't use is quantitative CT, which we are not using. So the answer is straight away without 3. That is 1, 2, 4 and 5. Yes? Is it easy, guys? So the answer is 1, 2, 4 and 5. Yes, yes. Yeah. Clear? Any doubts? So osteoporosis is again very important topic for INICET. So now nerve injuries, IC fracture, IT fracture treatment, osteoporosis. These three topics are very important. And now it is easy. Yeah, till now it was easy for everybody. But last year what happened is they have asked you this particular thing. We have learned everything, standard deviation, Z score, T score, that score, this score, everything we have learned. And INICET people, they have asked you what is fracs. So that is the intelligence level we have to enter into the INICET colleges. Okay, what is fracs now? What is fracs? So fracs, see, Osteoporosis is again a subjective, so you cannot just say that because only 2.5 you have your osteoporotic, right? Again, with the 2.5 score, again you might be having using steroids because you're already in your 50s and 60s, so you're using steroid, you're drinking alcohol. Did your parents have any fractures? What are did you have any pre-symptoms and all? So what this UK people have done, no, this is UK, so they are sophisticated people, they want everything under scores, so they have come up with this beautiful tool, that is fracture risk assessment tool, that is fracture risk assessment tool, that is your FRAX. So now what is this? This is nothing to do with us. We can give this questionnaire to the patient, he will fill the question. They will ask his age, what is his male or female weight, height, any previous fractures, any fracture hip, are you smoking, drinking, you have any rheumatoid, are you using any alcohol, or you have any drugs, everything he will ask, and he will tell you that this is the percentage, this is your percentage, and again based upon that percentage he will tell you whether you are risk of having further fractures. So that is the FRAX. So that is the tool which is used for assessing the risk. Clear? So just go through that tool. It is very easy. It is like your history taking only. So he is taking some again history and telling you this is the assessment. It is given in the percentage. That is the FRAX. 2 times they have asked you. Now 2024 May, 2024 November. What is FRAX? First they have asked only what is the full form of FRAX. Second they have asked you where FRAX is used. I mean, it is used in osteoporosis or where. So the answer was osteoporosis. Clear? So this question shows you should not only depend on PYQs alone. Okay. Okay, now here again back to our PYQs. Which of the following brace is shown in the image? Is it the Boston brace, the Milwaukee brace, the Taylor brace, or the Ash brace? Yes, this is a straightaway question. IBQs very, very important in INICET when it comes to orthopedics. So few IBQs always keep revising. Yes, it is Milwaukee brace. Very good. It is a Milwaukee brace. Where it is used? Milwaukee brace is used in a condition called scoliosis, right? Boston brace is also used in scoliosis. So how do you identify Milwaukee brace? Milwaukee brace goes up to your mandible. Your occiput is also protected, or it is supported. Boston brace is only for the thorax. So at thoracic level. So Boston brace is something like this, the corset. Okay, only up to your chest level, right? And then Taylor's brace. Taylor's brace, again a very, very important brace. The Taylor's brace, it is used for tuberculosis. It will support the dorsolateral spine, that is your DL spine, and that is called your Taylor's brace. Taylor's brace, very, very important. Okay. Next, Ash brace is anterior spinal hyperextension brace. So it is again used in the anterior spinal region, the chest region. Ash brace. So these are the 4 types of braces which you have to remember. Most important is Milwaukee only. Next is your Taylor's brace. Third Boston. Fourth is your Ash brace. Right? So those are types of braces, IBQs. Yes, one more IBQ. This is again a cakewalk for you. But you have to read the question properly. A 10-year-old. So 10 years old is first decade, male child, pain around the knee joint. There is a lesion at the distal femur, X-ray has been given. So X-ray findings are very, very important. So what actually you see in the X-ray, you see the bone and then you see for the periosteal reaction, right? So periosteal reaction is very, very important. Based upon that, you can tell what is this. So is it a giant cell tumor? We all know giant cell tumor gives what appearance on the X-ray? It gives the soap bubble appearance on the X-ray. So this is not the answer. Then osteoid osteoma, it is just a nidus on the X-ray, right? So there is no much of periosteal reaction. So for this, you have to go for a CT scan, as we already know. And chondroblastoma is again, it is usually seen in the epiphysis, if you remember, along with your giant cell tumor. So there is some cartilage involvement, right? So this is what? So yeah, this is your sunburst appearance. So you can see there is lot of osteoid. So what is actually the sunburst? Sunburst is nothing but osteoid forming tumor. That means bone is forming along what? Along your Sharpie's fibers. So what is the Sharpie's fibers? These are the fibers which are connecting your periosteum to the bone, right? Going back to your basics of the anatomy of the bone. And then these can be vessels as well. So whenever there is a bone which is formed along the vessels or along the Sharpie fibers, they appears as the sunburst appearance. And whenever there is a lifting of the periosteum, so lift of the periosteum, that is called as your Codman's triangle. So that is called as your Codman's triangle. So these two are very, very peculiar and very, very important for identification of your osteosarcoma. Yes. Yes, the most common pattern of involvement of the Pott's spine. So whenever we talk about the vertebrae, so these are the vertebra, and as you all know, there are discs in between them. So these are the discs. Right? Now tell me, if there is a tuberculosis, where you see it more often? Is it a paradiscal, that means around the disc? Is it central, that means inside the vertebrae? Anterior, posterior. So now if you see vertebrae like this, so now let us assume that this is anterior, this is posterior. Yes, yeah, very good, very good. So many of you answered it as paradiscal. So why do you think it is paradiscal? So the answer is paradiscal. So why do you think it is paradiscal? Answer here is osteosarcoma. Okay. So going back to the basic, I've told you basics, anatomy, very, very important. So now let us see if this is the vertebrae. Zoom. Now we are zooming the vertebra. And now we are thinking that this is your disc. So what happened whenever, yes, very good, vascularity. That is what I'm explaining. So whenever there is a blood supply to this particular vertebra, it is not that this vessel is going to this vessel is going to this. It is like this. Beautifully sharing between the brother and sister. So this vessel is feeding half of the upper vertebra, half of the lower vertebra. Then what about the disc? Who is feeding the disc? Yes? What is the blood supply of the disc? Yes, MBBS 8981. Can you tell your name? Are you told, right? Wait. Guruji something. Guru Raj? No, not you. Mahesh. Okay, it's very easy, Mahesh. Yeah. Yes, very good. You're asking me, Mahesh, is it avascular? You're asking me or you're telling it is avascular? So, okay. Because he is Mahesh, I'm answering him. Yes, what you have told is right. This is avascular. Yeah, disc is avascular. Doubtful answer. Okay, don't be in doubt now. Now you're free. It is avascular. Yes, you're right, Mahesh. It is avascular. Disc is avascular. Then you should ask me how it is nourished. If it is avascular, how is it getting its nutrients? So I will tell you, there is a beautiful phenomena called diffusion, right? So here there are end plates. This is where the beauty of the disc lies. So this is the end plate and this is the end plate. So what happens is these end plates have certain capillaries, and from there the disc takes the nutrition. So from there the disc takes the nutrition. So hence because of the avascularity, so this vessel which is supplying above and below and the disc as well by the diffusion, indirect supply. So what happens is the TB spreads that way. So the TB, your Mycobacterium tuberculosis, it comes like this and it goes like this. Okay, same color. I've used all the colors, huh? Orange. So this goes like this. So here is your tubercular spreading, spreading, spreading. So it is spreading around the disc. It is called as the paradiscal spread. And remember, always the TB spread is hematogenous spread. Hematogenous spread. So from the lungs, Barton's plexus, if you remember, from that it goes to the spine where it spreads around it. Why I have explained all this? Because again they might ask you in the exam, what is the base of this? So you should answer that also, right? Or not only paradiscal. So that is why I have explained you. So this is the theory and behind your answer. So the most common pattern of involvement is paradiscal. Central is in the center of the vertebra. Anterior is along this way like this, and posterior is like this. Okay, so that is why what happens is in the TB, whenever it is spreading, it might spread like this also. Hence, it is a very important to see for the abscess. And on the X-ray, usually it comes as the bird's nest abscess because it has this tendency to flow down on the ligament. So ALL, along the ALL ligament, along the PLL ligament, it flows downwards. So that is why you see that there is a bird nest abscess or the abscess destruction around the vertebrae in the MRI as well. So that is about the Pott's spine. Pott's spine is nothing but other name for TB spine. Okay? Yes. So now we are entering into the May 2024. Now, yes, now I can rest my voice for some time because now you can answer this. Come on, everybody. Read the question properly. Tell me the answer. I want everybody to answer. Everybody to answer. Yes. Why only 2 or 3 of them? Yes. Very good. Very good. Okay, he's explaining now, Mahesh. More than 60 years. That is why he had answered it as hemiarthroplasty. Very good, Mahesh. So the answer is hemiarthroplasty. Very good. So he has already explained it. Not total knee replacement, total hip replacement. But that option is not there, no? So don't mind. Hip replacement. Yeah. Yes. So now, yeah, let us understand what Dipan with Sarkar. What he's trying to tell is the man is 77-year-old, right? And now if they say that man is very active man, okay, and now they have given you the option as THR also, then you can even mark THR as well, right? You can even mark the THR. Or they have given you the man is very active and there is some acetabulum degeneration on the X-ray. When we took out the X-ray, there is some problem in the acetabulum as well. Then they are asking you about THR. Okay? Yes. Yeah, good. Yes, next one. Now this also you can answer. Yes, now answer this also for me. Yes. Okay. Not going to explain anything about this. Everybody have answered it wonderfully right. It is interlocking nail. Now you know the difference between interlocking nail and the PFN, right? That is also a nail. Proximal femoral nail is also a nail, and intramedullary interlocking nail is also a nail. You know the difference. I am not going to repeat it. We're going to understand it. Very good. So you have answered almost 2 important questions without me helping, right? Very good. Okay, now answer this. This is also very easy. A 55-year-old multi-para female patient presented to the ER with a fracture of the hip. Patient also had a history of 3 prior fractures. Which of the following is the most common site of osteoporotic fracture? Yes, very, very easy. Yes, yes. Going good. Come on, answer this also. So now we are answering all the May 2023 INICET questions, okay? Not some random questions. Very good, very good, very good. So whenever we talk about osteoporosis, that means the bones are weak. The mineral and the density both are weak, right? So that is why the most important fracture is your vertebrae fracture. And in that vertebrae fracture, which vertebra can anybody tell me? Is it the lumbar or dorsal or the cervical? It is the dorsal vertebrae, the thoracic vertebrae, especially at the DL junction. You find these fractures, and these present you as the wedge shaped fractures. So they are present as the wedge shaped fractures, right? So because of the wedge shaped fractures, the patient might go into a deformity which is called as kyphotic deformity. So kyphotic deformity, that is your wedge shaped fractures, okay? So this height of the vertebra is decreased. Now how will you know that whether this is a wedge shaped fracture or not? So this is the vertebra. In the wedge shaped fracture, what happens is there is a decrease in the height, right? So there is a decrease in the height. And now this patient goes into a deformity. If the multiple fractures are involved, that deformity is called the kyphotic deformity, right? Yes. And what is the one more important fracture in case of osteoporosis? The second one is your hip fractures. As they've already told you, the fracture, hip fractures, it could be an IC fracture or IT fracture. It is that, what is the third one? Third one. Yes. What is the third most important thing? Colles fracture of the wrist. So these are the 3 important fractures of osteoporosis. The first one is the vertebral fractures, especially the dorsal vertebrae, then the hip fractures, then your Colles fracture. Yes. Yeah, treatment, again, it depends upon the individual, right? It depends upon the individual. Yes, you can. Osteoporosis is treated by bisphosphonates, the calcium, the calcitonin, and the strontium ranelate. These are all the chemical, that is pharmacological treatment. So if you want to treat the vertebrae fractures, you can go for kyphoplasty, that is balloon kyphoplasty. So what we'll do, we introduce a balloon so that this will increase the height of the vertebrae, or we put the bone cement also and increase the height of the vertebrae, okay, to correct the deformity. So that is the treatment of the osteoporosis. So osteoporosis also we are dealing in great detail if you feel that, okay. So now here the answer would be vertebrae fractures. Okay, clear? Clear. Next. Now, a patient has come, 24-year-old male. He is reporting a pain, swelling, inability to extend his knee. Patient also have a history of fall while playing basketball. So here what is there? There is a trauma which is present, and then there are symptoms. The most important symptoms here you have to identify is extension of the knee. So extension of the knee is absent. Well, with pain and swelling. Right. So now he has given X-ray also for us. So looking at the X-ray, what you can see, anything in the X-ray? So is it a patella fracture? Is it a rheumatoid arthritis? Is it a hemiarthrosis or a tibial condylar fracture? What do you think is it? So not to confuse you, Shravani 3, do you think it is an hemiarthrosis of knee? No, Shravani doesn't want to think that. So just again, I want to give a little, patella went up. No. So here what I want to tell you is again the basics, anatomy. So anatomy, what is the extensor mechanism of knee? Can somebody tell me what are the extensor mechanisms or extensor mechanism of the knee? Extensor mechanism of the knee. So this is very, very beautiful. So this is your thigh. This is your tibia. In between, we have a very beautiful patella. Deepan 3624. Yeah, skyline view can help you, but this is also helping you. Okay. So listen, I'm telling you about the extensor mechanism here. So extensor mechanism, this is the muscle, you know, quadriceps, right? So these are all the quadriceps. What is quadriceps? That means there are 4 muscles which are there, and now this quadriceps is inserting into the upper part of the patella. And then we have the patella, and then we have this patellar tendon. Okay, this is going to attach near the tibial tuberosity, right? So this is what is that, you know, hamstrings. Quadriceps. And this is the patellar tendon. And now just move back and just make your legs straight like this. I mean, extend your knee. Now you see the quadriceps has been tightened, then your patella is also tightened, then it is the up to the tibial tuberosity, you can feel the tightness, right? So that is the extension of the knee. So the extensor mechanism of the knee includes the quadriceps with their attachment to the patella on the upper part, then the patella itself, then the patellar tendon, lower pole of the patellar tendon, and then your tibial tuberosity. So this is your extensor mechanism. Now what is happening? Now imagine that there is a patella fracture. So there is a breach. Yeah, I will tell you. Don't worry. That you ignore. There is nothing. That is something else. See, what you have to look here is only about this. Okay? That is something else. Artifact. So this is the patella fracture. Don't get carried about by the x-ray. You have to read. So there is a pain, there is a swelling, there is an inability to extend his knee, right? Inability to extend his knee, and there is a history of fall. So whenever somebody is not able to extend his knee, that means there is a breach in the extensor mechanism. So what is that extensor mechanism? It either be a quadriceps, either be a patella, or a patella tendon, right? So if there is a fracture of the patella, there is a breach. So there is a break in this extensor mechanism. So this complete extensor is by, one is the quadriceps tendon, patella, and the patellar tendon, right? So now what happens? Because of this pull, because there is a fracture in between, because of the pull on the upper pole, half of the patella is upside, and because of the pull on the lower pole, half of the patella is on the lower side. So this is called the fracture patella. So because the two tendons were strongly attached on either side of the pole, upper pole and the lower pole, they will pull 2 fragments away, right? So that is the patella fracture. And now to combine these 2 fragments, what we are using? We are using SS wire and K wires, right? So we are putting 2 K wires. So these are the K wires, and this is the SS wire in the figure of 8. Figure of 8, this is called as TBW. This is tension band wiring. So now you put the 2 fragments together. First fix it with the 2 K wires, the red ones, and then you put the SS wire, and now this SS wire you coil. So one like this, you pass the wire and then you will tie it. So this is called a figure of 8 fixation, right? So this is called as tension band wiring for patella fractures. So here we are talking about the patella fracture, and don't worry about this x-ray. This is some artifact here. This is some artifact here, nothing to do with the patella. So here the patella is broken, and you see that this has been taken in some other thing. They have put the limb in some place and they have taken it. Actually, I have to be careful before providing you with this x-ray, but it is just skipped my mind. So this is the fracture I was talking about. Usually you see patella here, right? So you see any breaks here, you have to always go for the lateral view of the patella, lateral view of the knee. And as somebody has mentioned, the skyline view, usually we don't take it in the trauma. This is mainly used for identifying the patellofemoral arthritis. Patellofemoral arthritis, right? For trauma patient, you cannot flex. So for taking a skyline view, you have to flex the knee. But in that pain patient, usually don't flex, but the skyline view is mostly useful for the patellofemoral arthritis, right? And for lateral view and the AP view is for the trauma, right? Now don't worry about the x-ray. Worry about the clinical condition. He has given you clearly the patient is unable to extend his knee. In case of tibia condylar fracture, the patient will have severe swelling, right? And he can either flex nor extend, right? And condylar fractures are very much visible on the AP view. So here you don't see any condylar fracture. So you have eliminated this. Then hemarthrosis of the knee, again x-ray is not needed, and there is no problem in the extension. Patient can flex and extend. And rheumatoid arthritis, again they have given you history of trauma. So whenever there is history of trauma, always think in terms of fracture only. Okay. So the answer is patella fracture. Clear, guys? Any doubts? Don't worry about that x-ray, okay? Okay, done. Next, a 22-year-old male patient with thigh pain. A CT scan was given. And what is this condition? Is it osteomalacia, sarcoma, Ewing's, or chronic osteomyelitis? So this is a direct question again in your INICET. So this was a CT scan which is given. 22-year-old male patient. Is it osteomalacia? Is it a sarcoma? It is a Ewing's sarcoma or a chronic osteomyelitis? I have clearly mentioned that this is a CT scan. So that is why it is very important to read what is this. Is this an MRI or a CT scan? So whenever we are talking about CT scan, that means the entire bone will appear white, right? And any lesion will appear darker. It could be an edema, it could be a tumor, or it could be an infection, right? So here if you see, again, yes, very good. So here if you see, the lesion is in the metaphyseal region. So the most common metaphyseal lesion is usually infection. And to tell it is Ewing's usually occurs in, Ewing's is seen usually in the diaphysis, right? And this diaphysis also, it is usually more destructive, right? So here you can see a lesion which is mainly in the metaphysis, and you can see thorough covering around that, there is a layer of covering around it. So there is a dead bone which is present inside a normal bone. So this dead bone is nothing but your sequestrum, and sequestrum is a specific feature for one particular condition, that is your chronic osteomyelitis. So the answer here is chronic osteomyelitis. So always stick to your basic. The basic here, first read which investigation is that. Is it an MRI? Is it a CT or ultrasound or what? So CT scan usually we see for bone, right? So in the bone, you see something very dead. It is the sequestrum, which is again covered by a normal bone here, right? So this is a chronic osteomyelitis, a case of chronic osteomyelitis. Right? Yes, in wings you see the onion peel appearance. Yeah, that is on the X-ray. You see the onion peel. That is a periosteal reaction. So multiple bone which is formed. That is your onion peel appearance. Okay. This is a sequestrum which we see in the chronic osteomyelitis. So this is usually can be an investigation of an CT scan. This is usually a case of your chronic osteomyelitis. Osteomalacia, what do you see in osteomalacia? You see fractures, right? Osteomalacia, you see loser's zone or a small fractures. And sarcoma, again you see there is a tumor. These two are tumor related. Okay, and chronic osteomyelitis is the infection. Is this clear? So this is an abscess formation here. Okay. See, again they have asked in 2023 also. What is the answer? Yes. Extracapsular neck femur fracture they're asking you. Neck of the femur are only two types. One neck is intracapsular, the other neck is extracapsular. Yes, the answer is nails. Very good. Nails, they have given just the intramedullary nails, right? So the answer is intramedullary nails. Good. Yes, now what is this? Which of the following layer is affected in the Salter-Harris type 1 fracture? So what is the Salter-Harris type? So Salter-Harris is for the pediatric population, right? So pediatric, especially for the trauma, and this trauma around the physis. So what is so special about the pediatric bones? So you should be very, very clear about this. So if you think this is a bone, so most important thing which we are worried about here is the growth of the bone, right? So the bone grows where? It grows in the physis. Physis is a area between the epiphysis and the metaphysis, right? So you have epiphysis, physis, and then the metaphysis. So the longitudinal growth is by your physis or the growth plate. So this is the longitudinal growth plate, right? So that is the physis. So whenever there is a trauma to this physis, we are worried. Why we are worried? Because whenever there is a trauma, it can disturb the growth plate. So whenever there is a disturbance of the growth plate, then you will result in the deformity or arrest of the growth. Right, so that is why you have to be very, very careful when dealing with the pediatric cases. You have to see whether the patient is having any problem in the physis. So for that, we have come up with the solution. So that is your Salter-Harris classification. So Salter-Harris classification is mainly to tell whether the physis is damaged or not. So the mnemonic goes with the word Salter itself, right? So though we have 6 here, types are only 5. Sixth one is an addition, extra one. Okay. So now remember, if there is type 1, that means there is only separation of the physis. So there is no problem in the epiphysis as well as metaphysis. Okay, now I have to tell you this also, right? So I have told you, let us assume this as your epi, meta, and this particular area as the black one as your physis, right? So the growth, as told you, will start in the physis. There are certain layers in the physis which helps in the growth. But to start with that, what I have to tell you is how the growth usually occurs. It occurs with the help of the stem cells or the reserve cells, right? So these reserve cells are present near the epiphysis. So coming to the layers of the physis, there are 5 layers. First one is the resting layer or the reserve layer, right? And then there is a proliferation, zone of proliferation. Then there is zone of hypertrophy, and then there is an hypertrophic zone. So these two are important for you. Though there are 5 zones, what are important for you is the resting or the reserve zone or the stem cells. So these are the stem cells which are present towards the epiphysis, and once you want the bone to form, these resting cells, so these resting cells or reserve cells, they produce more cells. So that is called zone of proliferation. So first there is a resting or reserve, and then you have zone of proliferation like this. So there is a multiplication of the cells which occur, right? And then you have zone of hypertrophy where the cells increases in size, right? And then you have zone of provisional calcification. So here mineralization takes place, the zone of provisional calcification where calcium and phosphorus act, and then you will have your metaphysis. So this is your epi, this is your meta, and these are the this is your physis. So there are areas like layers in the physis. Is this clear? It's very important. You have to understand. So this diagram is like this. I have made it ulta like this. Okay. So this is meta here and this is epi here. So the reserve or the stem cells is towards the epiphysis only. Then you have zone of proliferation. Then you have zone of hypertrophy. Then zone of calcification. Zone of calcification where your calcium and phosphorus gets deposits here. Right. And then that is formed as the bone and gets connected to the metaphysis. So that is how bone forms. That is how growth occurs. Now, so here, if you see this zone of hypertrophy is supposed to be the weakest area amongst the all. Weakest area is always the transition area. So in the bone, if you see metaphysis, epiphysis and diaphysis, you know the weakest area is metaphysis because it is a zone of transition from the epiphysis to the dia. So it has to go through the metaphysis. So that is the weakest area. So here also in the physis, the weakest area is the zone of hypertrophy. So whenever there is a separation of the physis or the fracture of the physis, it happens through this zone of hypertrophy. That you have to remember. So it happens to the zone of hypertrophy. hypertrophy. Okay, so whenever I say stage 1, that is separation of physis, that means I am telling it happens in the hypertrophy only, that is zone of hypertrophy, right? And then I'm telling you A, that is above the physis. What is above the physis? It is the metaphysis, right? So above the physis is the metaphysis. So the fracture is occurring above the physis, that is occurring at the metaphyseal area. L, type 3 is lower to physis. That means what is lower to physis? It is the epiphysis. It is the epiphysis, right? And T is through the physis. That means it involves the 3. That is, it involves the meta, it is involving the physis, and then going up to the epiphysis. So all the 3 zones are involved. And last one is ER, that means crush injury. So complete damage to the physis. And there is one more layer which is called the perichondrial ring near the metaphysis. That is the layer that also gets damaged. So remember, there are only 5 types of Salter-Harris classification with the mnemonic SLATER, right? So type 1 is through the physis, above is the meta, lower is epiphysis involving, through is all the 3 physeal zones, ER is complete damage, that is the crush injury. Clear, guys? Yes? Yes, everybody. I want everybody to answer. So now go back to the question. Now answer. What is the Salter-Harris type 1 fracture? Salter-Harris type 1 fracture is the fracture which is happening. Yes. Answer. A, B, C, D. Why there is no answer? Guys, is it A, B, C and D? What is the answer? So the answer here is you're waiting me to tell the answer. Okay. The answer here is hypertrophic zone of the growth plate. Yeah, good. Why it is taking so long for you to answer B? Weak. Signal is weak. Weakest layer. Okay, weakest layer is the hypertrophic zone of the growth plate. Okay, very good. So the option is B, that is Salter type 1 fracture. So what is this example of Salter type 1 fracture? It is your skiffy. So somebody slipped capital femoral epiphysis. If you go back and read, there is also slip in the epiphysis. So that slip in the epiphysis is again in this hypertrophic zone of the growth plate. Network issue is there. Oh, that is what I was asking. Now it is clear, network issue. Okay, only for you. Okay. Okay. Done. For rest, then nobody else is answering as well. You got bored, guys. So I'll not tell much, okay? I'll tell only little from now. Okay, now this is the answer for the Salter-Harris type 1. And now tell me, for example, if a patient has come with type 3, type 3 Salter-Harris classification injury. So what do you tell for his parents? You tell that this is okay, and you will tell no, this is not okay, or you will tell there is some problem, and what is that problem? Yes. So whenever a patient is coming, a pediatric case is coming to you, and you will find that there is a problem in the physis, and now this physis has reached the trauma, whatever is happening is reached to the epiphysis. That means there is a damage to the reserve or the resting zone there where the stem cells are present, right? And hence you have to counsel the patients that this might land up in the growth disturbances, because as the stem cells got damaged, there will be a problem in the growth. So you have to carefully follow that patient. Okay. Yes, you will tell it is not okay, and you will counsel the patient that nothing to worry much, but you have to follow that particular patient. Okay. Yes. Which of the following is a complication of the intermittent administration of teriparatide? Yes, this is a pharmacological question, I agree. So if I see anything related to ortho, I just pick it up and put it, because I want you all to have that complete set of questions from ortho. So a teriparatide is nothing but PTH, right? So synthetic PTH. So what is this? What is the complication you see in this intermittent administration of the teriparatide? Is this osteonecrosis of the jaw, the net bone loss, osteosarcoma, or the subtrochanteric fracture of the femur? Which one is the answer? Yes, 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 faster. So remember, whenever it is an administration of the teriparatide, there is a risk of osteosarcoma. There is a risk of osteosarcoma always. And osteonecrosis of the bone, it is again bisphosphonates. And even your subtrochanteric fracture of the femur also bisphosphonate. Okay. So the osteosarcoma is the answer. Okay. Osteosarcoma is the answer here. So teriparatide, always remember there is a risk of developing osteosarcoma. Yes, next set of questions. This is INICET 2023 May. Patient came with difficulty in extending in the distal interpharyngeal joint. So this DIP, medial 2 fingers. Injury to which of the following mark structures will result in inability to hold the paper between the fingers? So this is the marking they have asked. So this is the marking. Okay, is it A? Is it B? Is it C, or is it D? Like that. Yes, the answer is the ulnar nerve. Very good. So this ulnar nerve damage will result in a deformity which is called as the claw hand. So what will happen? There will be inability in the extension. Yes, the medial epicondyle. The medial epicondyle is the area where this ulnar nerve is present, right? Okay, and now this will cause the claw hand, that is the deformity, and it will not allow the DIP joint to extend. Yeah, radial nerve, wrist drop. Very good. And tell me what is A also. Why did you leave that? So what is this test? What is this test? This is called the card test. So this is called the card test. It is mainly for which muscles? Which muscles? Pad. Palmar interossei is for your adduction. Palmar interossei is for your adduction. Very good. That is your axillary nerve. And what does it cause? Axillary nerve. So whenever there is a damage, it is loss of abduction, right? And regimental badge area. Sensations on the regimental badge area. So this is for the axillary nerve. Okay, and this is the radial nerve, wrist to drop. So this is important fracture, that is your Holstein-Lewis fracture. Okay, whenever there is a fracture at that particular area here, to be precise, the fracture usually occurs this area. Okay, so there will be a damage to the radial nerve. Okay, and this is the CAT test for the pad. So the option here is medial epicondyle. Very good. Very good. Thank you for the answer. Okay. A patient presented to the emergency with pelvic instability. What will be the first step of management? Is it external fixation, internal fixation, blood transfusion, or a bedsheet draping around the pelvis? Okay, the answer option is given already. For what, Deepan, you have typed A? Nerve injury leading to malunion is A. Which nerve injury leading to malunion? I didn't get that. Okay, now we are done with this nerve injury, that is ulnar nerve. Medial epicondyle is the answer. Are you talking about the tardy ulnar nerve palsy? So that is because of the growth, excessive growth. The ulnar nerve is getting damaged. Okay. Okay, now what is this answer for this? So whenever you have a pelvic instability, so pelvic instability is one of the most important emergencies you have to deal, right? So in that emergency conditions, you don't think about any fixations, you just do a bedsheet draping around the pelvis. So this is the answer, very, very important. That is the pelvic binder. Very good. So because there will be a lot of blood loss, you have to first try to get a closed ring of the pelvis. Yes, that is the pelvic binder. Very good. So if you don't have a pelvic binder available, you can do a bedsheet draping. You can do a bedsheet draping. This is this draping at the level of the greater trochanter. Greater trochanter, right? At the level of both the greater trochanters, you are going to do. Yeah, intraocular nerve injury. Yeah, okay, ulnar, correct. So whenever there is an acute pelvic injury, it is a very important emergency and it should have a team approach. So whenever you're dealing in a casualty and as receive a patient with the pelvic fracture, it is not for immobilization of the limb, it is for control of the bleeding. So if you go back again to the anatomy, so this is the sacrum, a very, very important structure which is present at the back. And now this is connected to the iliac bone like this. And this iliac bone in the front is, that is coccyx. In the front, it is connected to your pubic symphysis, right? So you have pubic symphysis, the iliac, wings like that, the sacrum, and here you have ischium, right? So this all together forms a ring. So there is a ring which is forming, connected behind by the sacrum, in front of by pubic symphysis, right? So this ring has to be this ring has to be in contact, or this ring has to be closed, because there are many internal structures, many different vascular bundles which are present inside this ring. So now what you do, this pelvic ring along the greater trochanters, two greater trochanters, you bind this. Okay, so whenever you bind it, then you're closing the ring, protecting the organs as well as the damage to the vessel. So you prevent or control the bleeding, right? So that is the thing we are doing here. So whenever we are receiving an emergency pelvic injury, it is a team approach, right? So first thing what you have to do is always stabilize the patient first. So how do you stabilize? Always go with ABCD. You know this, right? So ABCD: airway, breathing, circulation, and diagnosis. The final E is environment, right? So first you have to look for the pulsations for patient going into shock, right? Shock. So that for that the circulation is very important. For that you have to always, blood transfusion should be in your mind. So before putting the blood, you have to close, no, where it is going. So for that you will put the bed sheet draping as we have discussed, right? Bed sheet draping. And then you have to stabilize the C spine as well. So cervical spine as well, you have to take care of this. And then you have to check for other abdominal injuries, because pelvic injuries are a high trauma, high velocity injuries. If the patient is coming with a pelvic trauma, that means there is a high velocity. So you have to put all this in mind. So first you have to go for airway, check for the breathing, then circulation. And once the circulation is stabilized, you have to look for the shock, and always put blood transfusion in the mind, not only transferring overloading with fluids. And then to control bleeding, whatever is going, you have to control it. That is by your bed sheet draping, right? And then always take care about the C spine and look for other abdominal conditions. So this is the pelvic binder I am talking about. This is AO prescribed pelvic binder. If you see, it is at the level of GT. It is draped at the level of the GT. So that is your pelvic injury. And always catheterize the patient. Catheterization is very important. And you have to look for urethral injuries also. Okay, urethral injuries are also very common with the pelvis. So catheterization again for this shock treatment only. So that is the thing. This was direct question which was asked. The answer is bedsheet draping around the pelvis. So this is the bedsheet draping I was talking about. So this is the GT we have identified, and we are going to drape it this way. Okay. Right. Okay. Now what is the answer for this? This is very important. Tibial fracture. After 12 hours, he became unconscious. Axillary petechial lesions, breathlessness. What is the diagnosis? So this diagnosis is very easy. What is the answer? Of course, A. Confidence. Of course, A it seems. So whenever you see a long bone fracture, and now there is a symptoms of CNS involved. It could be either with the confusion or unconsciousness plus petechiae plus SOB, that is shortness of breath. All these, they are the way for your beautiful answer, that is your fat embolism syndrome. So of course A. So very confident about the answer. So now if you're confident about the answer, you have to tell me the treatment as well. So how do you treat the fat embolism? Because if most of the people are confident, no, they will level up the questions. So leveling up is you have to understand the treatment. So what is the treatment? Why it is not shock, hypovolemic shock or hemorrhagic shock? One important clue of that is after 12 hours. So shock is an immediate reaction, right? As well as your compartment syndrome is almost immediate, but in compartment syndrome it is a local reaction. You will not have petechial breathlessness and all. So you are going to rule out compartment and the shock, because whenever they are talking of, yes, duration is more, whenever it is usually after 24 up to 72 hours it occurs. So what actually occurs? The fat gets escaped and it will create or incite inflammatory reactions in the capillaries. So these inflammatory reactions mainly occur in the brain capillaries and lung capillaries. So this will result in confusion, dizziness and restlessness with the petechiae, that is skin involvement, which is resulting in your fat embolism syndrome. So what is the treatment? Treatment, you usually go for hydration, right? And you go for hydration. And then what is the treatment for this? anticoagulants, right? Right, heparin. Okay. Yes, that is your fat embolism. So this is your conjunctival patache. This is your axillary petechiae. So this is conjunctival and these are the axillary. Yes, hyperbaric oxygen therapy also is being advised for your fat embolism syndrome. Okay. Yes. Which of the following ligament is injured in this image? Yes. Can you answer this? Is it the glenohumeral, the coracohumeral, coracoacromial, the glenoacromial, or the acromioclavicular? Fast has to be done for what? Fast is focused abdominal sonography, no? It is for the identifying the pockets. Yeah, E-fast. That is for trauma. Trauma of cases, you have to do the fast. Yes. Yeah, which of the following ligament is injured? Can you tell which of the following is injured here? Yes, abdominal injuries. Very good. Yes, is this the AC joint? So here I'm talking about, yes. I understood the E-fast. Now come back to this question, please. Which of the following ligament is injured here? So you're going to read this X-ray. So X-ray, you will find this particular humeral head here. Then you will have, sorry, this is the humeral head. Then, yes, this is the clavicle which is displaced above, and this is the acromion, right? This is the coracoid process. So here you see that gap between the AC joint, the gap between the AC joint has been increased. So this is an acromioclavicular joint, acromioclavicular injury. Deepan, you're still in that fat embolism Gertz criteria. We are dealing about the AC joint. Can you please come back to this? So which of the following ligament is injured here? So we are dealing about the AC joint. So this is the acromion and this is the clavicular. So whenever there is a gap between these two, it has been increased, and because of this sternocleidomastoid here, sternocleidomastoid attachment here, it has been pulled up. The clavicle is moving upwards. This is called as the AC joint involvement. So the answer is AC joint, right? So this is the AC joint. So you see, this is the complex structure which is present here. So this is the acromioclavicular ligament, and similarly we have the coracoclavicular ligament, the AC ligaments and the CC ligaments, right? And then whenever there is a damage to the AC, it slightly moves up. But if the CC is also damaged, then this is called the type 3 injury. So completely there is a loss of this particular structure and the clavicle completely goes up. Right? So that is about your AC joint, the acromioclavicular joint. So here this is the normal X-ray. This I want to teach you because this is something new. So this is the normal X-ray where this is the joint is in line, and here if you see the joint has, the clavicle has gone up and there is a disturbance. So the complete disturbance happens only when there is a break of CC joint. So if it is only AC ligaments which are damaged, it is slightly moving up, but it has to move more than 2 mm. If it is more than 2 mm movement, that means the CC joints are also disrupted. The CC ligaments have been disrupted. Yeah, low molecular weight heparin. That is what I've told you, no? Coagulants, heparin, yes. Low molecular weight heparin. Okay. Okay, so that is the AC joint and the acromioclavicular joint. So we have a classification that is called the Rockwood classification. So based upon that, we will know whether it is type 1, type 2, type 3 and type 4. So this is the Rockwood classification. So I have told you in type 4 onwards or type 3 onwards, what happens is there is a damage. So this is type 3. So from type 3 damage, there will be involvement of CC joints as well. So if the CC joints are gone, that means the clavicle completely goes up. If it is only AC joint, you see still the clavicle is intact. Okay. So that is what I want to tell you, the small thing here. And November 2023. Yes, this is you have to answer. Come on, quick. We'll complete in more 10 minutes. Yes, a 43-year-old male had a RTA causing a defective hip abductor mechanism. So this is the hip abductor mechanism. So very, very important question. Whenever somebody is talking about the hip abductors, that means there are two important abductors you have to remember. One is your gluteus medius. The second one is your gluteus minimus, right? Medius and minimus, which are supplied by your superior gluteal nerve. This is anatomy integrated question, right? So now they're asking you, it will result in abnormal gait, right? And then what does a positive Trendelenburg gait does? So whenever there is a damage to these three, it will result in loss of abduction, and that will cause a gait which is called as your Trendelenburg gait. Okay, Trendelenburg gait. And now this Trendelenburg gait can happen whenever there is damage to gluteus medius, minimus, or your superior gluteal nerve, right? So here, which of the following is not an indication in terms of involvement? So gluteus is involved, medius is involved, minimus is involved, superior gluteal nerve is involved. Now the answer here is your sciatic nerve. Sciatic nerve doesn't have any role in case of your Trendelenburg gait. Is that clear, guys? Yes, the answer is B. That is your sciatic nerve. Very good. Yes. Now what is a test? So there is an important test which is called as the Trendelenburg test. So now let us see what is this test for. So Trendelenburg test is mainly again for the abductor mechanism. Abductor mechanism, there are two important muscles, abductor medius and abductor minimus, abductor medius and abductor minimus, which are supplied by the superior gluteal nerve. And what is Trendelenburg test now? So yes, how do we do this test? We all know that whenever we stand on the two legs, so these are the two legs we are standing, so the hip is maintained. So how will you tell that this is maintained? You will see the posterior superior iliac spine. So the two, let us assume that this is the posterior superior iliac spine, this is the posterior superior iliac spine, right? So now these two tests are maintained. I mean, like these two are at the same level, it is maintained. Now what we are doing? We are doing a single stance. That means we are standing on a single leg. And now even though we are standing on a single leg, still you can see the main points are maintained. How is this happening? Now? Can you hear me now? Okay, fine. Okay. Yes, yes. Thank you. Thank you for letting me know that. Yes. Now again you can't hear? Is it clear? Is it clear, guys? Can you hear me? Okay, thank you. So now what I was telling you is the Trendelenburg test. So the Trendelenburg test, we are looking at the hips from the behind. That means the point which we are looking here is the posterior superior iliac spine. We are trying to make that point at the same level. So two spines are present, that is iliac spines. So two spines at the same level, that means the hip is maintained, as I've marked in the image. So this is the PSIS, that is posterior superior iliac spine. So two PSIs which are maintained at the same level. That is on the two limbs, when the patient is standing on the two limbs. But even though the patient is standing on the single limb, that is single stance, which is called technologically, still we are able to maintain the same level. The points are maintained at the same level. But how is this happening? How can we maintain that at the same level even though we are not standing on the two limbs? That is because of the abductor mechanism. So what this abductor mechanism does? So what it does is, here you are putting the weight on this limb. So this is the, assume that this is the weight bearing limb. This is the weight bearing limb. Now what happens is, this weight bearing limb, what does it do? It contracts his abductors, and now it pulls this also, and so that it is at the same level. Understood? So whichever limb we are putting the weight, that will, because of that abductors are working, the abductors gets contracted and they will pull the hip to the same level. So instead of that limb sinking, instead of that particular ASIS going down, because of this abductor mechanism on which we are putting the weight, that limb abductor mechanism will do what? Contraction of that abductor muscles and pull the hip to the same level. Now imagine if these abductor muscles are not working, there is no mechanism, what will happen? The hip will fall down. That means that side of the hip will dip. That is called the dip. This is the dip. Understood? Confusion? Just see this particular image. Nothing you're going to learn, nothing you're going to remember, revise, or all the old whatever knowledge you had about Trendelenburg, delete everything. Just, yes, I'm repeating, just look at this particular image only. What I'm trying to tell is, so we are going to, yes, I know. Look at this hip. So what I'm trying to tell you is, usually whenever we walk like this, we put weight on two limbs like this, right? But have you seen our hips dipping this way, that way? Not that typical lady walking, we walk straight, right? So why that is happening is, now assume that I am taking a point which is called as the posterior superior iliac spine from back. So now assume that this is a patient. I am standing in back of the patient, right? And now I will ask the patient to stand on both the limbs. He is standing on both the limbs, and now you can see that both the hips are at the same level, like this. So now the patient is standing on the two limbs, and both the hips. This is one hip, this is the right hip, this is the left hip. Okay, right hip and the left hip, they are at the same level. That means the reference point is posterior superior iliac spine. But what I'm trying to tell is hip. That's it, okay? Bony prominence is posterior superior iliac spine, but commonly I tell it is hip. So both the hips are at the same level, okay? Now I ask the patient to stand on left hip. Now the patient is standing only on the left limb. He is standing only on the left limb, right? So now what should actually happen? Because the weight is falling on the left side is stable like this. It is straight. But the right side, the weight is unable to take. No, there is no limb on the right side. So that hip has to dip. The hip has to fall down. But now what is happening? The left side abductors are contracting because of the weight they have, and because of that contraction of the abductors on the left side, the right hip is raised. Understood? And now Similarly, if this particular person whom I told to stand is having some left hip pathology, so his left hip abductors are not working. Left hip abductors not working. So this mechanism is absent. So there is no pull of the right hip. Okay, there is no pull of the right hip. Hence, you see dip on right. Understood? Here, because left limb abductors working, they are contracting. Working means what? They are contracting. And now they pull the right hip up. Okay, so the right hip is pulled up so that they are at the same level. But here, because of the left hip abductors are not working, because he's putting weight on the left hip only. Understood? Whenever we put the hip, the muscles contract. Here, even though muscles contracting, but there is a damage to the abductors. Hence, these abductors are not able to pull the right side hip. That is why you see a dip on the right side. This dip, whenever you see, it is called as the Trendelenburg sign positive. Trendelenburg sign positive. Is that clear? Clear? No, I want you all to type whether it is clear or not. You want me to repeat once again? Very, very important this is. This is very, very important. They will ask questions on this. Okay? Yes, very nice, clear. Thank you. Thank you so much. Yeah, okay. So that is the answer. And NEET PG, they have asked similar question. So they have told that left side hip, the patient is having dip on the right side. So where is the pathology? If the patient is having dip on the right side, where is the pathology? So the pathology is on the left abductors. You got my point? Okay. Yes. Very good. That is the thing. That is the thing you have to remember. So, putting the weight, whenever they put the weight, the muscles have to contract. And this muscles on which we are putting the weight should contract, and that should act as abductor mechanism, pulling the opposite hip. Right? Pulling the opposite hip. Very good. Yes, okay. So that is the Trendelenburg test, Trendelenburg sign, Trendelenburg gait also. Gait also you will have dip on the opposite side. So whenever he is walking, this particular right side is getting into dip again. Okay. And left side, because left side is normal, because the left side hip is, because the right side hip is normal, the left will go up, and again whenever it's putting left side weight, again it goes down. So the hip goes down and up, goes down and up. That is also called as the Trendelenburg gait. Okay, or the Waddling gait. Yes. Yes. Now I think you can answer this. This is one more type of gait they're asking. So the first rule for Trendelenburg is, if it both sides affected also, it is not very much clear. You cannot tell it as a Trendelenburg gait, but you will find dip. Yeah. What is the answer for this question? So this is again one more very much easy question. It is usually asked in the exam. A 26-year-old patient presents in the OPD after a road traffic accident, complaining of unable to dorsiflex and avert the ankle. So loss of dorsiflexion as well as eversion, right? Yes, this is the CPN. This is the CPN. Yes, this is a CPN. So whenever there is a common peroneal nerve, it is involved, we'll have what? This is called as the high stepping gait. This is called as the high stepping gait. So what is high stepping gait? So here we'll have whenever the both hips affected, we'll have the waddling gait. Right? So Trendelenburg gait, if one hip is affected, both hips are affected, we have duck. That is the waddling gait we'll have here. Okay, and then here we have the high stepping gait. Why? Because there is a loss of dorsiflexus. So for walking, what should you have? So for whenever you want to walk, so you're walking like this, right? You will walk like this, one step, and then you will raise one step and put one more step like that. So for lifting up from the ground, you need dorsiflexus, right? So if not dorsiflexus are not working, what you do? You try to lift the hip and then you put it, right? So that is called the high stepping gait. So here the ground clearance is absent for them because the dorsiflexors are not working. So you can't, the ground clearance is not present for them because they can't dorsiflex, right? So then they will use the hip flexors, they will entirely lift the limb and then they will put the limb down, entirely lift, and this is called as the high stepping gait. This is bilateral hip Trendelenburg, that is your waddling gait. Circumduction is seen in paralysis. So circumduction gait is seen in paralysis of the muscles, especially the hip muscles. So here they will entirely walk around like this. They will entirely turn the limb in a circle and then put. Stamping gait. This is stamping gait is seen in B12 pernicious anemia deficiency, where they are weak and they stamp like that. Okay, so that is called the stamping gait. But what here which is important for you is here CPN around the neck of the fibula. Whenever you have the fractures neck of the fibula, you have to be very careful. This might damage our very important common peroneal nerve, which is an important supply for the dorsiflexors and the everters of the ankle, right? Of the ankle. So whenever there is a loss of dorsiflexion and loss of eversion, which will result in loss of the ground clearance while you're walking, that is the gait, it will result in the high stepping gait. Okay, yes. The next one, this is very easy. A 24-year-old patient presents with the anterior shoulder dislocation. Yes, most common dislocation in the shoulder is anterior, whereas in the hip, the most common is posterior. Please remember, don't get confused, okay? In the hip, it is posterior. In the shoulder, it is anterior. So whenever there is a recurrent shoulder dislocation, yes, I want you all to answer. Recurrent shoulder dislocation. Recurrent shoulder dislocation is happening. So what is this? So assume that this is your what? The shoulder, the glenoid fossa, right? And now this is your humeral head. Now this is the anterior labrum. Anterior labrum is nothing but a covering, a cartilage covering, and this is your posterior labrum. Now this head is coming forward like this. So whenever it has to come forward, this is the bone I'm talking, and just imagine there is a cover, there is a thin cover covering around it. For example, wait. Now imagine this is your labrum, the extra covering. Okay, this is your labrum, that is the extra covering which is present like this. Okay, so this is the labrum and this is the bone. And now whenever you have to bring the head anteriorly like this, see, when I want to come like this, I'm disrupting this labrum and coming. So what will happen? So initially, habitually, whenever there is a multiple anterior dislocations, there will be tear in the labrum. So this tear in the labrum especially in the anterior inferior area, because the dislocation is mainly in the anterior direction. So anterior inferior tear in the labrum is nothing but your Bankert's lesion, Similarly, I told you that this is the labrum, and hence we are having tear here, like this. It is tearing. Now I see the head is also coming out. Head. See, now the knuckles are also touching the bone like this. So there is a defect in the humeral head. So the defect in the humeral head as well. So it is like the Newton's law. Each and every action will have opposite reaction. So the action is in the labrum. The reaction is in the humeral head. This is called as the Hill-Sachs lesion. And it is usually the posterolateral defect. It is usually seen in the posterior of the head on the lateral aspect, superior. Posterolateral aspect, that is your Hill-Sachs, right? So the labrum is Bankert. So here the answer would be your Bankert's lesion. So this is the Bankert's lesion. Okay. So whenever you see that is the anterior inferior aspect, so that is your Bankert's lesion. Okay. Yes, guys, are you following? Any doubts? What is fracture of necessity? Is Deepan with us only, or he's attending some other class? Okay. Deepanvita Sarkar. What is fracture of necessity? And now what is the answer of this, guys? In which of the following fracture the 3-point bony relationship is maintained? They're asking maintained. Very good. So the answer, this is a straightforward question, right? This is supracondylar fracture. So whenever there is supracondylar fracture, it is the fracture which is above the condyles. So hence the 3-point bony relationship is maintained. Very, very easy, right? We should expect these type of questions. Yeah, the complication in supracondylar fracture is anterior interosseous nerve, which is the branch of median nerve. That is what you wanted to tell. Okay, it is a branch of median nerve. So the answer here is supracondylar fracture, right? Lateral condylar, medial condylar, elbow fracture. In all, the 3-point bony relationship is maintained. So what are these 3 bony points? The medial epicondyle, the lateral epicondyle, and the olecranon. So these are in the triangular fashion in case of your flexion. So whenever it is flexed, it is triangular. Whenever it is extended, it is a straight line. Right? So that is the answer for this. Okay. Next. A 33-year-old man had caused an ankle fracture. So there is an ankle fracture. Hawkins classification was done to diagnose, plan, manage this fractured ankle bone. So for which type of fractures does this Hawkins classification apply? Yes, supracondylar fracture, very good. Malunion, and this results in the gunstock deformity. Very good. Yeah, it is later stages. That is malunion. Okay. Now, what is this? Hawkins classification. So, Hawkins classification is used for which type of fracture? Yes, Hawkins classification is for the talus. Very good. So this you have to remember. So the classification names are also important. So talus is Hawkins classification which is used. Okay. Yes, right. Then this. In outpatient department, a 55-year-old male patient presents with arthritis that symmetrical. Okay, symmetrical, as the word we see symmetrical, it's like we know what is the answer. And to our this thing, they have given morning stiffness as well. So should I explain anything about this? Go in the exam straight away, you're going to mark rheumatoid arthritis. No more thoughts about it. So guys, these are all direct PYQs, no PYTs, all direct previous year questions. See how easy they are. Okay, so the answer is rheumatoid. Or somebody wants to ask you about psoriatic, what will they tell you? They tell you that there is an involvement of DIP and there is an involvement of the skin lesion, or they are using the Casper's criteria to diagnose it, or there is a nail which is involved. So these are all the words which they put in for you to answer as psoriatic. Osteoarthritis, they will begin directly. It is a degeneration or wear and tear, right? Wear and tear, and usually it is seen that at the end of the day, so as they use it more and more, at the end of the day they will find all these symptoms. And gouty arthritis, if someone has to say, it is alcohol induced, so they will tell alcohol it is used. So the first MTP, the great toe is painful, or else if they want to tell, they will use the knee which is painful, and they will tell you that is the crystals have been seen, it is negatively birefringent, right? And recently in the NEET PG they have asked about the pseudo gout. What is pseudo gout? Where their crystals are positive, and again it is usually seen in the knee. CPPD, that is calcium pyrophosphate deposited. Okay, so that is about your all the joint. These are the words they use for asking the questions, and this is a straightforward question. As soon as you see, you just read the question, it is a knee pain so and so, only they have given the x-ray, so just close your eyes again and go for osteoclastoma, because it is a soap bubble appearance, and you can clearly see that the lesion is present in the epiphysis. But be careful, the chondroblastoma is also seen in the epiphysis as well. And what is the difference between chondroblastoma and osteoclastoma? Yes, this is after maturity. So the physes are fused here. That is a very important. Here it is seen before the physes close, and you can see calcifications, right? Chondroblastoma, that means cartilage involvement. So both are epiphyses. You have to be very careful, but this picture is our favorite picture, right? So soap bubble appearance, you can see all this soap bubble appearance, lucency, expansile, aggressive epiphysis, this osteoclastoma. Okay, now these are important questions again, where you need help of a mentor. So you know there is an open fractures and there are closed fractures. So closed fractures, we have understood certain treatments such as nails, plates, screws. So for open fractures, you can't put these nails, plates and screws inside the body. Those are the implants. Why? Because for the open fractures, we have threat of infections, and bone infections is supposed to be most notorious, and once the bone is infected, it's infected for life. This is the dictum we follow in orthopedics, so we have to be very careful to see that the bone is not infected. So whenever we are dealing with open fractures, open fracture means the fracture is exposed to the environment, so we are not putting the implants inside, because these implants can act as a medium for the infection to proliferate. So now what we do an external fixation. That means we fix the bones from the outside, and for that we have certain equipment which you all must know. The first type of equipment is with the rods and the clamps, right? So we have certain rods, certain clamps, when we fix that with certain pins. The second type of fixation is called a ring fixation, which is in the form of rings, which gives a 360-degree stability to the bone, right? So for example, if this is your limb, so this is a person's limb, okay, and now what I do is, if this is a particular fracture, so what I do is I use pins. So these are the pins I'm using, okay? So these pins are placed like this either side of the fracture. These are the pins, and now I put rods over it. Okay, these are the rods I'm putting, and now I secure it with the clamps. So these are the clamps. So rods and clamps, or the rail rods like this. And now for this, what I do, if this is the limb, I do a 360 degrees fixation like this. Similarly, I put the wires. These are called the olive wires. And now again, these are also stabilized with the help of certain clamps, right? So this is called as the Ilizarov fixation. Ilicerov fixation. The wires I use here, as I've told you, these are called the olive wires, not the K wires. Here I use the pins. These pins are named as the Schanz pins. These are the Schanz pins. Don't confuse. These are the Schanz pins, right? And now these are the rods I have told you already. So these are the rods and this is the clamps. So these are the two types of fixators. One, I have the rods and clamps fixator. The second one is the ring fixator. And now what they have asked you. So if you see, I have put only one rod. That means only one little stability. If I put two rods and that too close to the fracture, it is maximum stability. And this is called as the uniplanar. That means I'm fixing only in the one plane. And now if I take this limb like this and I see this is a fracture, and instead of putting rod at one side, what I've done is, so now this is the pin I have put and this is the pin I have put. Now I'm putting one more pin from this side. Okay. And now I'm putting a rod, this rod to this side, this rod to this side, and securing it with the clamps. Now if you see, I have put rods on either side. This is called as a biplanar fixation. This is the uniplanar and this is the biplanar. Uniplanar, everything onto one side. Biplanar on two sides. So this will add much more stability to the fracture. So this is all external fixation. We are fixing it from the outside, not from the inside. So now let us see what he is asking us. Okay. So now I have told you whenever we have only one rod is the least one. So least stability. Whenever it is two rods, it is more stable. And biplanar is even more stable, right? So second one is even more. But 360 degrees is very much stable, right? This is very much stable. Now the answer is, there was a fracture and now he wants to understand what is the correct order of stability. Always Ilicerov fixator is the highest stability. So C is the highest one, right? And then the least is 4. So D is the least, I think, right? So D, A, B, C would be the answer. C is more Ilicerov, then comes the biplanar, then comes the uniplanar with two rods, then with uniplanar with one rod. Clear, everybody? I've been little fast. Clear? Any doubts? Yes, I want a thumbs up or I want you to ask doubt. Okay, no keeping quiet. Yes, clear. The others? No doubts. Okay. Others. Yes. Okay, fine. Okay, this we have already done whenever we have marked it, we have come to know that the anterior dislocation of the shoulder is resulting in what damage? It is resulting in damage to the axillary nerve, right? So this applies the deltoid. Yes, very good. Thank you. The deltoid is responsible for the abduction. Right? So anterior dislocation of the shoulder. Korean heart. Thank you. So anterior dislocation of the shoulder will result in. So this is very important, guys. Nerve damage. Nerve damage is again one more important table which is important. Okay. So shoulder axillary nerve. Next we have hip. Because posterior dislocation of hip is most common. Important damage is your sciatic nerve. Okay, very, very important. Yes, regimental badge area. Correct. Now that is the answer. And now, a patient presented with the femoral shaft fracture, what is needed to put a skeletal traction? So again, very, very important question. See, these are all straight questions from INICET. I have not made it up. Direct questions I am teaching you. So if you want to revise it, just go through the questions. You have entirely covered 5 years of PYQs, right? So skeletal traction is that particular traction. So this is your limb again. And for example, this is the tibia bone we have here. And there is a fractured tibia here. Okay, there is a fractured tibia. And unfortunately, okay, sorry. Let's take femur fracture. Okay, now this is your limb. And now, So this is your femur. Okay, and then you have your tibia. Okay, and this is your patella. So we have a femur fracture. Femur fracture. But loss of deltoid contour. Yeah, for abduction it is there. So now imagine, so now let us come to the this thing. So this is the femur fracture. I'm telling you there is a femur fracture. So usually this patient will come to casualty, right? This patient will come to casualty. I'm giving you a real scenario. What will happen is this patient will come to the casualty and we'll take the x-ray. We'll see that he's having a femur fracture. We'll tell them that you have to go for an intramedullary interlocking nail. But because India is a poor country, he will not have money. He will ask for time. Now he'll tell, can I do the surgery tomorrow? Can I do it day after tomorrow? Because I have to bring money. And sometimes we'll have these cards, like you have this in Andhra Pradesh, we have Arogyasri card. That means poor card. That means these people, they get free treatment under that card, some government schemes. So for the schemes to get approved, we have to wait for 1 or 2 days. So that is the scenario actually. Or else if the patient is having any comorbidities, right, or if he's having some other polytrauma where you have to wait for the surgery. So all this, what I'm asking for, all this, I'm just asking for the time, nothing else. So you need some time to fix the fracture. Till then he will die with pain, because the fragments of the fracture femur are very heavy and they keep moving. They might, that pain might kill him. So what we are doing is, we will put one important thing which is called as skeletal traction. So the word skeletal means we are taking the help of the bone itself to put traction. Right? So traction is what? We are just pulling the limb like this so that it is maintained. So the fragments are aligned. Right? For example, imagine this is a stick and it is broke. So if you put it like this with the help of, if you're able to maintain it like this without fixing it, there will be some amount of reduction of pain. So further damage is decreased. So that is what we are using here. We are using skeletal traction. Yes, Thomas splint we can use. Just take some breath. Okay, Thomas splint we can use, but I'm trying to explain you more beautiful than Thomas splint. Thomas splint is a cumbersome procedure where you have to go get one thigh ring, get two things, and then tie this. We don't usually use Thomas splint. It is an important question but not clinically done. But skeletal traction is something which is clinically, which is usually we do in the procedures room, which we usually do, but nowadays again we are not doing. That is one more important thing. So listen, Thomas splint I'll tell you, but listen this. So now what will happen? We are doing skeletal traction. That means we are using the bone to help us to give the traction. So how are we using the bone? So for that we need some important things. So the first thing what we need is one pin. So we put this pin. Okay. So we put this pin through this bone. So this pin, there are two pins which we can use. One is the Denham's pin. Okay. One is the Denham's pin. The second pin is Steeman's pin. So we have two pins. So Steeman's pin and Denham's pin. So what is the difference between this Steeman's pin and Denham's pin? I'll tell you. So before that, what is the Sean's pin? Where it is used? Yes, I want you all to tell me the pin now. Sean's pin, where it is used? So Sean's pin is like this. Hey, it is okay, Mahesh. No need to feel sorry. Sean's pins, where it is used is my question. Nobody is answering. Yes. Sean's pins. I've told you just now, no? Yes, external fixation. Very good. So, what I have given there, the threads are at the end. So, these threads are going into the bone. So, they will give stability to the pin. So, this is called the Sean's pin. So, whenever you see threads at the end of a pin, that is called the Sean's pin. Okay. You don't see anything, a sharp pin-like structure with a sharp edge like this. So this is called your stem and spin. This is called your stem and spin. And then you see something little blunt like this, but the threads are in the center. So this is called your Dunham spin. This is called your Dunham spin. So now tell me, the shank spin is used in your external fixation. This is clear for everybody, X-fix. And this stem and spin is used for younger patients, right? And this Denham spin is used for osteoporotic bones. So you have to always deal in orthopedics, you have to deal with bones, right? So first you have to understand what is the pattern of the bone, whether the bone is strong or whether it is a weak bone. Based upon that, you should choose the implants as well, right? So if you put a stem and pin in a weak bone, the bone may further explode because of that tightness, right? So now what we do is, whenever the bone is weak, we will give it a Dunham spin and we give it threads, so that the threads will hold the bone even though the bone is weak. Right? So selection of the pin is important, and then once the pin is selected, for the pin you will put a stirrup. So now what you do is, now we are going to put the pin like this. For example, let us assume that this fellow is a young fellow. We have put the pin like this. Now what you do, you will hang this stirrup to it like this. You put this stirrup, and now what you do, you put the weight to it. So this is the pulley like this, and this pulley you attach it to a bag. This is the weight. So this is how you give a skeletal traction. So this is give 10% of the body weight you can add as the weight. 10% of the body weight you can take. That means if the patient is 60 kgs, up to 6 kgs you can put as the weight. So this is the skeletal traction. So what all you need? You need the pin, you need the stirrup, and second one you need this frame, right? So that is called the Bowler-Brown's frame. Bowler-Brown's frame, right? So BB splint, that is called as the BB splint. This has been asked in the FMG exam, right? So that is the BB splint. So all these structures we need. sorry. So Bowler stirrup, Stemans, Dunhams. We don't want Thomas splint, we don't want K wire, we don't want Bowler's frame also. So it is BB splint, not frame. The wordings are different. So, and one more thing, only 3 options are there here, no? So 3 are enough: Bowler stirrup, Stemen pin, and Dunham spin. So the answer is D. Clear, guys? So that is about the external fixation. Thomas splint is a splint which can be used, but that is not for the skeletal traction. So skeletal traction is not Thomas splint. That is what I wanted to tell you. Thomas splint is another type of traction, right? So there are 2 types of traction. One is skin traction, one is skeletal traction. Okay, so skeletal is you are putting an invasive pin inside the bone. So that is the skeletal traction. Thomas is a type of skin fixed traction. Skin. So here what you do in Thomas splint. So this is the limb. So here you put the Thomas, and then there are 2 rods which we put, and then we connect it with the W shape, and here we wrap it with the cloth. So this is your Thomas splint, and then you put the limb on that, and then you can tie this limb to here. So it is just a type of skin traction where you are using the skin as a traction, but you don't put any pins into it. Hence this is not a type of skeletal traction only. So the answer is not Thomas splint. Clear, guys? Pratik, thanks for that. But I am worried I'm taking a lot of time. It is already 3 hours past. No, you people are getting bored. Don't know how many more questions we have. Okay. Done. So that is it, guys. Good evening, Shubhasri. Okay. Are we done with the pins, with the tractions? Just we go to the next question. This is a very, very easy question. You have to answer it because it is eponyms of the fracture. That is, few fractures have names, nicknames. So what is the base of the first metacarpal fracture called? What is the name of 5th metacarpal fracture called? What is the name of base of 5th metatarsal fracture? 2nd metatarsal fracture. This is nothing to do with the concept. What you have to remember is second metatarsal is March fracture. As we know, this is a kind of a stress fracture. And then fifth metacarpal is a Jones fracture. First metacarpal is a Bennett's fracture. Fifth metacarpal is a Boxer's fracture. So Boxer's fracture, you just punch like this, no? So there is a fracture in the fifth metacarpal. Neck, then upside. Base is down, neck is up. Okay. So just match accordingly. A is B. A is B. 2 we got. B is D. Again 2. C is A. Time taking process. Okay. B is the answer. Thank you for all your love, guys. Thank you so much. I'm glad that you're all understanding it. That's it. Yeah, Jones fracture is very, very important. Remember, it is the metatarsal. Jones fracture is the metatarsal. But what is important is you have to understand the difference between the base and the neck. So something at the end is the base, neck is towards the phalanges. So this is the neck, right? Neck is towards the fingers. So this is the base, this is the neck. So whenever it is phalanges, it is head and neck. Whenever it is toward the tarsals or the carpals, it is the base. Okay? Done. Yeah, we have pseudo-Jones. So Jones is the bone fracture. Pseudo-Jones is involvement of the tendon. That is peroneus tertius tendon is involved. So that is the pseudo-Jones. Okay? Okay, done with that. Next. Yeah, this is somewhat confusing for us also. It is said that the fishtail deformity, this was asked in 2022 of INICET. So I thought of bringing the image of it, but I forgot. So usually this fishtail deformity is something like this. So this is usually seen in a child where they are present with the distal humerus fracture. So whenever there is a distal humerus fracture, you see this fishtail deformity. So something like this, the lateral condyle goes like this, something like this. So this is the fishtail deformity. So that is a surgical emergencies. What they have told about fishtail deformity is the distal humerus, specifically talking about the lateral condylar fractures. Okay. Yeah, humerus, distal humerus. Very good. Correct. Now one more interesting. This is also okay. Arrange the steps of the Thomas test. Now before that, tell me what is a Thomas test. So Thomas test is one test which is used for identification of the fixed flexion deformity of hip, right? So what is this fixed flexion deformity of hip? Now don't get confused and don't get annoyed by these terminologies in ortho. This is usually PG level question. Okay, to be frank, first of all. So this is a fixed flexion deformity means what actually happens. There is a story. This is the hip joint. So whenever the hip joint will have muscles around it, right? So whenever there is a pathology in the hip joint, this hip flexors, what are the hip flexors? That is the iliopsoas. That is the iliopsoas joint, iliopsoas muscles which get involved. So that is the hip flexors, right? So the muscles, iliopsoas muscles which get involved, that are the hip flexors. And whenever there is a pathology, the pathology may be a TB hip or a avascular necrosis hip or a rheumatoid hip, whatever is the pathology, the muscles get involved and the muscles will not do their action. Understood? So if there is a flexion deformity, that means the extensors are not working. Okay. So the hip goes into flexion means what happens is the hip completely is in flexion. So there will be contraction of the iliopsoas. So the hip goes into flexion. Understood? So that is the flexion deformity of the hip. Now, so let us imagine that you are having a flexion deformity of hip. Now, can you walk if you have a flexion deformity of hip? So imagine that your hip is coming towards this like this. Hip is flexed like this. So you can't walk, right? So for walking, you need to have the limb to be touching the ground. On flexion, the limb comes up. So to compensate that flexion, what happened is the spine, the lumbar lordosis increases. So the spine will come to your rescue, will increase its lordosis, which is called as exaggerated lumbar lordosis. Understood? So hip goes into flexion because of the contraction of the iliopsoas, the flexors of the hip joint. Because of this contraction of the hip joint, the patient cannot walk. Once imagine flexing your hip and walking, you can't walk, right? So now what happens is body compensate. So which part of the body compensate? The spine. The spine will tell I am there for you, and it goes into exaggerated lumbar lordosis, pushing the hip down. So flexors somewhat they become less contracted, right? And if you still remember, the iliopsoas origin is from lumbar vertebrae, right? So that is why the lumbar lordosis happens. And now the flexors little relaxed, and now they can walk, but at the cost of exaggerated lumbar lordosis. Now what happened? What this Thomas, he's the Thomas. I have bought the original Thomas for you. So this Thomas, what he have observed is, now because Thomas has come to know that the spine is acting smart and not letting us know the hip flexion deformity. So there is some problem in the hip flexion, it is not letting us know. So what Thomas has done, he has invented one test. So what he has done, first put the patient in supine position. So no need to walk. First you don't walk, sleep nicely. Okay. So then he said normal limb you flex. Normal limb you flex. So now he is flexing the normal limb. Now the spine gets released. Spine gets released. That means the lordosis is lost, right? The lordosis is lost. Then now the lordosis is lost, the spine is released, the normal limb is flexed. Now this flexors get contracted because the spine is not helping, other limb is also not helping. So it has lost complete help. Now it shows its true form, that is the contraction of the iliopsoas. So while contraction of the iliopsoas, what will happen? So you will see something like this. This is called as the fixed flexion deformity of the hip. The knees go up like that. So you can see there is a gap which is formed here. So this is the gap. So now what you do, you take a scale, you put this along the couch and now along the femur like this. So this angle what you measure is called the fixed flexion deformity angle. Okay, understood? So whenever you see something like this is called flexion deformity. And how do you measure the angle? So you put one line like this, the other line like this. So this angle, how much angle it is making, that is the amount of deformity, that is the flexion deformity which is having in that particular hip. So that is the FFD. Understood? So, so in all this, measuring is the last step. With the common sense if you want to answer. Okay guys, are you there everybody? Understood? So first we are going to sleep, make the patient sleep. Okay. Then we are going to flexion of the normal hip. Ensure that the patient is sleeping. Okay. And then we are going to flex the normal hip. Then the squaring of the pelvis and ensure that the ischial tuberosity is a normal behavior. Like, so once the spine gets relaxed, what you do is you square the pelvis. That means you see that the two hips are the same level. Now here you take the help of ASIS, that is anterior superior iliac spine at the same level. That is called squaring of the pelvis, right? And then what you do before measuring the before measuring the ankle, you see that this is touching, the ischial tuberosity is touching the couch. That means you're not over exaggerating the deformity, right? Sometimes what we do, we try to over exaggerate the things. So what is the indicator for us here? So we should not over exaggerate the things. That means the ischial tuberosity should touch the couch. So that comes just before the measure. So ensure that 4 and 3. So 4 and 3 should come. Then before that you are doing squaring of pelvis. The first one, check for exaggerated lumbar lordosis, and then you are going for flexion of the normal side of the hip. So before that you will check for lumbar lordosis, right? So lumbar lordosis you will check. Then you will flex the normal hip, right? So after flexing of the normal hip, you see that the both hips are at the same level. Then you will ensure that the ischial tuberosity is touching the ground, and then you measure. Right? So that is the answer. That is the Thomas test. This has been asked INICET directly. Okay. But this is a little, higher level. But you can use your common sense making this as the answer, because measuring is usually the last, and the ischial tuberosity should touch, and then you start the measurement. Again, this is, if you have attended the postings, then you can actually answer this question. Okay, which of the following is the even I don't want to know. 4 questions more. 4 questions more, an easy one. Which of the following is the last thing to occur in case of compartment syndrome? I think this is very important to know. That is the pulselessness. So for the first one is the pain, which is very, very important symptom. The patient should have an excessive pain. Even the pain should not be relieved. Not relieved on medication as well. It is not relieved on medication, right? And now the sign, what we see for the sign is passive stretch. So sign is the passive stretch. So that is the compartment syndrome. So whenever the patient is having pain on the passive stretch, that is sign for compartment syndrome, and there is an excessive pain which is not relieved on medication. And last one to appear is pulselessness, guys. No confusion. Pulselessness is the answer. No looking for pulselessness. You have to look only for the pain. And pallor or paralysis, not accountable that much. And this is what you see. What is this deformity? So you are usually, the neighboring people know that you're a doctor, and they will ask you to come to their home to show this particular deformity. And as soon as you can see, this is a spot on diagnosis. So what is this? Very good. This is called as the club foot. And now once you have identified as club foot, they will feel very happy that the doctor knows everything about the human body, and they will ask you when and what should be done. So this is called as the CTEV. Yes, CTEV, or the club foot. And what is the treatment for this? This is the deformity, right? Ankle and the foot deformity. The order of the deformity is this way. So this is cavus, adduction, varus, equinus, right? So these are the deformities which we can see here. And now when will you start? How do you treat it? We treat it with the serial casing. So you put plasters, POPs. So serial casing, every week we put the plasters. So this will go up to somewhere around 6 weeks. So you have to correct the cavus first, then you will correct the adduction, then you will correct the varus, then you will correct the equinus. This is called the Ponseti's technique. This is called the Ponseti's method of correction. So when will you start? You just start within few days. So that is the answer. As soon as you start, that is within 1 week of birth. Okay, 1 week of birth you should start. You put the serial casing, and once the casing it is corrected, then you maintain with the CTEV shoes. So you use the CTEV shoes. Okay, that is about the CTEV. Very good. Yes, now what is the answer for this? A male patient with history of RTA have severe pain, shows posterior dislocation of the hip and the pelvic bone fracture. What would be the treatment modality? So we already know whenever there is a dislocation of any joint, the first and foremost should be reduction. So it is always reduction you have to do, and always closed reduction is attempted first, then followed by the open reduction. And just remember, if this particular posterior dislocation is with acetabular fractures, then you have to take a CT scan and then be sure about the reduction of closed reduction. Okay, sometimes even if you attempt close reduction, they are not maintained, so the reductions are not maintained, then you go for the open reduction. That means you open the joint and reduce it, right? So what is the thing here? What we do, the treatment modality is always reduction first, always attempt for the closed reduction. But whenever there is an acetabular fracture or pelvic bone fractures, you have to always go for CT scan, be sure about the reduction, okay? Or else you have to plan it under meticulous condition, okay? Even sometimes you reduce it but it is not maintained, that means you reduce it and it will again pop up back. So for that you can go for open reduction, but you should try for a closed reduction. Okay, so the answer is closed reduction. Last question. Which of the following does osteoporosis have? So this we have already dealt, right? The chemical analysis. So what is the answer? Can you answer this for me? We'll end the class with a happy smiling face, seeing to all of your answers. What does the osteoporosis have? Does it have low calcium? Does it have high ILP, low LP, normal ALP? Yes, very good, very good. I'm happy to see. The answer is normal. So everything is normal in osteoporosis, right? And high ALP is seen in Paget's disease. So whenever you see there is a high ALP, close your eyes and mark Paget's disease, okay? So chemical analysis, everything is normal in case of your osteoporosis. So that is, we have completed 2021 say 2025 PYQs, direct PYQs of INICET. Easy? I forgot to put the thank you slide. So thanks a lot. Thank you so much. I've enjoyed so much. So this is my Instagram. If you have any queries, you can DM, or we have our PW Meded Instagram channel as well. And we have a Telegram channel where we are actively taking all the doubts. All the 19 faculty are present there. So you can ask all your doubt, queries, everything. And any doubts, would happily answer all your doubts. So even if you don't have doubts as of now, even if you want any topics which could be dealt in a detail, or you have any small topics you want me to take Telegram sessions also, we are happy to help you out there. So you can follow the Telegram, Instagram, all the grams, okay? But please gain out of it, okay? So that's it for today. We are done. 3 hours. Solid PYQs, okay? Very, very important. All PYQs only. So here and there we have touched the topic also, but these are direct PYQs of INICET. Happy? Any doubts? Guys, I'm still waiting for you all to ask any doubts. So, okay, Mahesh, happy. go to sleep happily. But see, listen, everything is easy if you keep revising. If you have understood everything today, but after 1 month, again, if somebody is asking you these questions, it might look hard for you. So keep revising. So all this you have to, that is a Telugu word, is telling Iragadi Saru. So happy. So listen, you take all the small topics. So for example, I've told you the osteoporosis, the hemiarthroplasty, the IT fractures and all. You keep writing in small books so that before the day of the exam, you can just read only these 4 or 5 points which are important, and in the exam it will be easy for you. You can use that time for the other questions which you're not much prepared, or some bouncers like questions. Okay, so thank you so much. Yeah, bye, good night.